Uh, we're going to start in a minute or two. There we go. Hi. We want to stay on time today, so I guess I'll get going. My name is Dan Geschwind, and I want to welcome you all to the event. I'm the director of CART, the Center for Autism Research and Treatment at UCLA. And I'm a neurologist and a geneticist, as well as the Senior Associate Dean and Associate Vice Chancellor of Precision Health at UCLA. And I've been directing CART now for 15 years. Let me just start with some introduction before we get going today. I want to just introduce CART to you a little bit for those of you who may not be quite as familiar. Hopefully you can see my screen now. That's the kind of core group at our last scientific retreat. We have the point I want to make is that we are a multidisciplinary group from many different backgrounds, from psychology to people who are studying mouse genetics, to people who work in the clinic and diagnose and treat patients with autism, to neuroimaging genetics. It's an extraordinarily multidisciplinary and broad set of collaborations that's necessary to really understand autism. We're dedicated to improving the lives of all children and adults with autism and their families through research, patient care, and then training the next generation of researchers and clinicians, of course. The research encompasses many areas, from identifying early markers and intervention for high-risk infants, treatment development, genetics and genomics, stem cell models of autism, as you just, and as you'll hear, if you've watched some of the videos, you've especially seen some kind of remarkable advances due to kind of galvanized by stem cell models and Engelmann syndrome. Other mouse models as well, brain imaging, EEG, which is a electrophysiologic biomarker, et cetera. We give pilot grants to bring other people into campus, into autism research, and continue to grow our community, our reach, and our effectiveness. The clinical services involve multidisciplinary care, diagnosis and evaluation, treatment. We're building the capacity more and more to give scholarships for low resource individuals and families. The clinics and programs include the CAN clinic, which is focused on diagnosis of autism, the Caring Clinic, which has a medical model and is focused on children who have defined genetic syndromes, as well as a college to career transition program, which was started several years ago with philanthropic kind of stimulus to be able to take our children and kids, well, some of them are young adults, we should say, just shows what kind of parent I am. Young adults who are at UCLA, of which there are hundreds with autism, and begin to help them make that difficult transition from a very structured environment at school to the workforce. In terms of training, I mean, almost all of us who are here are totally dedicated to training. We recognize that we really need to build the workforce, and most of us get great pleasure out of our trainees and watching them grow and establish their own careers. We have undergraduate volunteers, many students who are in gap years as entry-level staff, graduate students getting their PhDs, postdoctoral fellows, junior faculty, as well as community outreach. And we have a number of programs, Coffee Cart, where we give casual lectures to the community. We have a distinguished lecture series, which is much more formal. And we have Sigmund Scholars, which I'll show you, I think, in one of these next slides. Of course, equity, diversity, inclusion has been a mantra which has even grown over the last several years. In fact, some of the programs at UCLA have been going into the community, like Connie Casseri's programs, treatment programs, into diverse communities for a decade. We have been also for more than a decade with one of my colleagues who's going to join us today from WashU, John Constantino, who I really give credit for driving this forward. We have an Autism Genetics and Human Diversity project, which is one of our main genetics activities, where we're recruiting underrepresented groups, in this case, African Americans with autism, who are substantially underrepresented in autism research. We have this statement from our, that we placed last year. Hopefully, we put a lot of thought and care into this statement, and we all have rallied around this concept and our commitment to anti-racism. We're showing some of the Sigmund scholars, which are students who are undergraduates at UCLA, who get to spend summer research in a laboratory in CART. And we're beginning to focus the Sigmund Scholars Program, which is named after the co-founder of CART, Marion Sigmund, who left us way too soon. And this is in honor of her extraordinary contributions to the field and to UCLA and to many of our lives. These students are extraordinary, and we're hoping to bring them into the field of autism and to also support students from diverse backgrounds. I'm putting some information up here. On the bottom right is our new Director of Development, Chris Garbato, and his contact information. All of this is on our website, but I just wanted to give that introduction. I'm going to do this clumsy stop sharing with Zoom. Hopefully that worked. And that kind of notion about the clumsiness is, really reflects what's been going on the last year, more than a year now for almost all of us. We skipped 2020 due to COVID restrictions. And we're thrilled to offer this program this year in a virtual format. And we'd love to get feedback on it from you. Of course, we'd much rather see you in person, but at some level, this is perhaps the best of both worlds, where people can watch the videos at your own leisure, and then come and we can spend all of the time in discussion and asking questions. The one silver lining in the cloud is that we have people attending from all over the world, which is generally not possible when we do this in person. So our speakers provided fantastic talks ahead of time, and we hope that you're able to watch those talks before today's event. And our live program today will feature live discussions with the speakers and will be moderated by the faculty from CART, who you'll get to meet. Let me just start with a few boring housekeeping things. On Zoom, you'll see a couple of boxes at the bottom of your screen. You'll see a box called Q&A. If you have any questions or comments for our speakers or about the program, please type in these into the Q&A box, and our moderators will be able to field your questions. I hope we have time to get to all of them, but you know how these things go. We may not be able to. You can view the full program agenda and information about our speakers on the CME's website. Check the chat box for the link. Our team will post it there for you. And we're going to leave the pre-recorded talks for the next 3 weeks. They'll be available. And we'll also record these live sessions, and we'll email you a link shortly after today's event so you can re-watch them. We're asking all attendees to fill out an evaluation of the program. The link to the evaluation is in your confirmation letter. These evaluations will be very helpful for us in planning future events. After all, we're doing this to have the maximum reach and maximum impact in our community, and to share what we're learning about autism with you, as well as to get feedback from you. So we're so glad that many of you also sent in questions. So, believe it or not, I was less verbose than usual. And we are what I think is slightly ahead of schedule. I introduced CART to you, which we're all very proud of. I just want to say one thing, since I have another minute or two before we're not on time, out of time. UCLA has been an extraordinary place for me to develop my career. I've been here since my residency in neurology, and never did I come here thinking that I would stay. And certainly for the last, over 25 years and 22 years as a faculty. What's kept me here is partially this center, but even more importantly, the collaborative spirit and my colleagues. There are extraordinary people at UCLA, and one of the things that makes it really amazing is that we have top researchers in almost every discipline, and they're willing to work together, to talk to each other, to build a hope for the new future. And I really think that I've been around and traveled a lot, many of us have, and seen other places. And what really makes UCLA unique is its collaborative spirit and our researchers' willingness and ability to work together. So with that, I'm going to introduce the first keynote speaker. And again, another advantage of being able to do this virtually is that we've been able to invite several of our very trusted, respected, admired colleagues from outside of UCLA to help us in this endeavor today. So the first session will be with the keynote speaker, Dr. Nathan Call from Emory University, who will be discussing addressing challenging behaviors exhibited by children with autism. And he will be introduced, and this session will be moderated by Dr. Rajuta Wilson, a pediatric neurologist in the Autism Center.
Thank you, Dr. Geschwind, for that introduction, and good morning, good afternoon, good evening to everyone. I'm Rajuta Wilson, and I'm a behavioral child neurologist at CART, and it is my pleasure to introduce you to our first keynote speaker, Dr. Nathan Call. Welcome, Dr. Call.
Thanks. I really appreciate the chance to be here. I appreciate Dan's introduction. The trusted, respected colleagues are probably coming next, though, I'm assuming, right?
I don't know about that, Dr. Call. I'm about to give your bio, so I think it's going to be clearly evident how well respected you are and your expertise. So
totally admired, respected.
Somebody mute him.
So let me start by providing that introduction. Dr. Call is an associate professor in the Emory University School of Medicine in the Department of Pediatrics. He's worked at the Marcus Autism Center since 2006, where he has held many positions as a clinician and directed clinical programs. He currently serves as the clinical director for the center, and in this role, he oversees all clinical activities and works with providers and other center leaders to develop new clinical innovations. Dr. Call has a very active research agenda, which is quite impressive in addition to his clinical roles. And he's published over 60 papers and book chapters on the treatment of challenging behaviors exhibited by individuals with autism and related disorders. And I can personally say I've had an opportunity to visit it. It's an incredible center that you run there, and the services that you provide for these families and children through young adulthood. So thank you for being with us today, Dr. Call. And thank you for your excellent talk. I very much enjoyed viewing it, as I'm sure others did. And I'll go ahead, though, and start by asking you to give us a sort of short overview or kind of recap of your talk as we get ready to answer questions from our attendees, please.
Sure, happy to. And I know that Dan mentioned that one of the advantages of this format is that people can view these talks at their leisure. I think a lot of people like me, finding some leisure time is tough these days. So I expect that not everybody's maybe had a chance. So I'm happy to give a quick synopsis. So I absolutely, have dedicated most of my career, my clinical work and research to working with individuals with autism who exhibit some form of challenging behavior. And I also at the same time approach that clinical work from a perspective of applied behavior analysis, or ABA. And much of the literature around treating, especially the more severe forms of challenging behavior, are rooted within that ABA framework. And so the talk that I gave and what I was hoping to try to do is address two things at once. One was to give a little bit of that context, a little bit of what that approach looks like, and some of the frameworks that we tend to use when we work with individuals with challenging behaviors, but also try to give a little bit of the insight into some of the real strengths that come from a foundation in behavior analysis when doing this work, but also where there are some real opportunities for expansion, and where some of the just historical idiosyncrasies of how behavior analysis has developed over the last century or so have led to some areas of some blind spots, I guess I would say. And again, coming at this from the perspective of applied behavior analysis, I hope it's okay for me to be a little bit self-reflective of that field, and even maybe a little bit self-critical at times, to think about how that field needs to maybe approach some research questions a little bit differently. So to the first of those points, when talking about how applied behavior analysts who have experience working with challenging behaviors approach these types of clinical problems, really one of the main things that we're trying to do is when I talk to a family, for example, I see them in the clinic, and you ask a lot of questions and ask them what's going on in their life and in the life of their loved one who might be engaging in these behaviors, and inevitably ask the question, well, what have you tried so far from a behavioral standpoint, right? Now, again, I'm approaching it purely from that standpoint. Obviously, medications are a part of any approach these days, but suffice to say that most of the kids, by the time they get to see me, all the easy stuff's been tried, and in this day and age, easy stuff typically includes medications. And so if they're seeing me, it's usually because psychopharmacology has not really produced the kinds of benefits that they were hoping to see. So in any case, kind of asking, like, what have you tried from a more behavioral standpoint? Have you done anything at all? And the vast majority of families will say, yes, we've tried stuff before. It hasn't really worked, or it's been spotty. You kind of hear things like, well, mom looks at dad and dad looks at mom, and they say, well, yeah, there was that time we did that, and fill in the blank, time out, or token economy, or, we tried planned ignoring, or whatever, right? And they have some set of strategies. And what you tend to hear is that success is kind of intermittent or hit and miss. And there are some really good reasons why that tends to be the case. The largest being that when we think about how we approach these challenging behaviors, the most critical thing from a behavioral standpoint is what is maintaining that behavior? What's causing that behavior to persist? And usually that's involving, what are those consequences? What are the things that are really, from the perspective of the individual, what are they getting out of this behavior? For many of the folks that we serve, these behaviors are really almost a form of communication, right? And so I think about a kid who maybe learns to be aggressive, and they're aggressive because in their prior history, parents, in an attempt to calm him, have found that if they give him an iPad or a preferred snack, that'll calm him down. That'll end that episode of challenging behavior, which is good on a short-term basis. But from a long-term standpoint, what he's learned is, next time I want my iPad, start to act a little bit aggressive, and people will give that to me. And so that process of kind of understanding what's the function, what is the purpose that the behavior serves from the standpoint of the individual, is really critically important. And so what we see is lots of examples where one treatment for any individual might be effective sometimes, but not others. And that's oftentimes because the behavior might serve more than one function. And so when the child engages in problem behavior and people have learned to give him an iPad, well, if now he's engaging in problem behavior because people are asking him to do something he doesn't want to do, well, giving them an iPad isn't going to work in that situation. And so you see how these treatments can be intermittently effective. And so a process that we utilize, an assessment that we use, is functional assessment, to really identify and nail down exactly what the purpose of the behavior is for that individual. It can be kind of complicated. It can be laborious. And it certainly for more challenging behaviors, it requires a kind of a center or a skill set, and in some cases, even a facility that allows you to do that safely and manage those behaviors safely, and staff that are trained to do these things well. But it's something that we have seen again and again is really a pivotal piece of information, and that if the intervention is based on that result, the results of that assessment, far more likely to be successful than if we just were to choose them arbitrarily. And so that process of functional analysis, very data driven. And again, from a behavioral and ABA standpoint, or a behavior analytics standpoint, that background of kind of looking at how behavior analysis evolved, right? The early stages, early development of behavior analysis was based on this idea that folks wanted to focus on directly observable behavior, take data, make data-based decisions for the individual as opposed to groups. And that was really something that is kind of bedrock principle in that ABA world, which serves us very, very well when it comes to working with one kid. When I want to work with one child, I want to know what kind of outcome I can produce with that child. And so taking data every 10 minutes, I get another data point and I can see, when I apply these consequences or this behavioral strategy, the behavior is getting worse and then it's getting better, and I can turn the behavior on and off. That really, that background in what we call single subject or small N research designs is critically important as a clinical team and helps us to be efficient. We make sure we're not doing a lot of things with a kid that aren't productive, and we know when we're having success so we can push the envelope and make sure we're making gains. So it's really helpful in that standpoint. It's also then opens us up to certain types of research that are very, are almost where innovation starts to happen, right? And you think about innovation takes place because a kid shows up at your door who has a problem you haven't dealt with before. And so we're going to take data and we're going to assess and we're going to figure out how to treat that behavior. And because we use these well-controlled designs at the individual level, and that individual becomes kind of their own control group, if you will, we're able to demonstrate an outcome or a treatment effect with one individual. So that's really a powerful methodology for that kind of research. And again, I would argue that's really where innovation takes place. The downside is that's far too often where behavior analysis stops, because we who come through that tradition get trained that is a really effective approach, that's how we use data clinically, and that's how we approach research. And so there are whole journals dedicated to publishing that type of research. The downside is that the only people who read it are people who are already convinced by that kind of stuff. So in terms of being able to influence other consumers and be able to speak to constituencies and audiences who maybe aren't already deeply immersed in that literature, that it really doesn't extend beyond a small subset of colleagues. And so that's where, some colleagues and I here at our institute have worked really hard over the last 5 or so years to try to start to broaden the base. And part of that, again, comes down to what types of research questions are best answered by which types of methods. So for example, I said single subject, really, really good for figuring out what's working with one kid, and for iterating and innovating. Great, that's important work and it shouldn't be neglected. But there are a bunch of research questions that extend beyond that. Things like, well, how probable is that particular effect? If I get a good outcome with one kid, what happens if I do the same thing with 50 kids? Are all 50 of those kids going to show the same kinds of outcomes? And there's actually a nice study that was done by Tris Smith and one of his doc students, where they showed that behavior analytic literature that's based on single subject research is particularly susceptible to something we call publication bias. In essence, a good example is the study that I think we talked about in the talk on pica. Pica, ingestion of inedible objects. I always tell folks, if you want to see a really cool X-ray collection, I'm your guy. Like all the things kids have swallowed that show up on an X-ray that look really scary, and they are, because it can be life-threatening. We as a field in behavior analysis, the small group of people who treat challenging behavior, have had pretty decent ideas about how to address that behavior for a decade or two. And yet, when we went back and looked at the literature, the largest treatment data set that had ever been published had 3 kids in it. So that really opens us up to this concern about, well, sure, those papers have 3 kids and they showed great outcomes, but how many times did someone else use the exact same protocol and it didn't work? But because it's really hard to get negative results published, we don't really know about that. So for all we know, there's 2 or 3 papers that have 3 kids in them. Maybe that means that there's 6 or 9 kids where this has ever worked and every other time it's failed. We don't know. And so we've done some work to look at things like consecutive controlled case series analyses, which is a methodology of essentially retrospective chart reviews, look at every kid who walked through our door for the treatment of pica over a 3-year span. And we found we had 15 kids, and we found that when we followed a particular protocol, we had really good outcomes, an effect size of 1.8, which is really considered pretty effective. So that was really helpful to show that it's not just cherry picking your successes and publishing them, that these approaches can be successful in even that kind of a format. And then moving beyond even into things like randomized clinical trials and implementation science, and starting to study what are the barriers to the uptake of these treatments, because we know that they're oftentimes challenging to implement. And so developing an intervention that works really, really well in my center, where I have well-trained staff who wear protective gear if they need to, and specialized space, and everything's done with perfect fidelity, like that's great. We can show that that outcome is possible. And again, from a single subject standpoint, we might look at it and say, look, we made the little line go down, hooray, it's all meet at the bar for beer because we feel like we did a good job. But if that treatment can't be generalized into the home and the caregiver can't sustain it, and that those outcomes can't be sustained, then that means it's really not that impactful from the standpoint that's most meaningful, which is this child and this family better off because of the services that we provided? So that's moving into another whole area of research of implementation science and understanding what are our outcomes and what actually facilitates us producing good outcomes or stands in the way of those outcomes. So you asked me for a quick synopsis, and I think sometimes you put a quarter in me, you got to listen to the whole song. So it maybe went a little bit over time there, but even so, I hope that the folks who, if they haven't had a chance to look at that, maybe that'll give some context as they look at it going forward.
No, I think that was excellent, Dr. Call, and perfect in how it captured everything you've touched on and the main sort of points. And as we have questions come in, I think one thing that I'll maybe start out with to touch on two of the points that you made there. One, in the fact that how do you disseminate information, to those individuals who are not as deeply immersed in the field? So, to other local intervention providers, ABA companies, and the fact that, as you had noted, how do you sort of translate what you guys see at your center and the data that you have into the community? And what I'll say is that as a clinician, I'm often asked by a lot of families, how can they get their sort of ABA specialist or behavioral support team to work on specific difficult behaviors after trying what you described as XYZ, fill in the blank of what we've done. So do you have sort of key tips or strategies that can be translated from what you found at your center to the home for some of these problem behaviors, or some general approaches that you might suggest that may not be traditional intervention approaches or ABA specialist approaches?
Yeah, so I think, ABA as a profession, ABA or behavior analysis as kind of a field and a science goes back to like the 1920s, 30s, something like that. But as a profession, it's still relatively new, right? It's only been this century, 20 years or less, that folks have been credentialed or certified as a behavior analyst and been able to kind of bill insurance. And you've seen this big expansion in terms of the numbers of providers. And I think what that means is that, as with anything that's new, there's kind of this kind of early phase where there's some variability, if you will, in terms of the quality of some of the providers and the types of experience that they have. My experience has been when I talk to, for example, folks who are coming through for training, and you get folks who maybe have their BCBA or they're a provider of behavioral services, and you ask them their experience around addressing challenging behavior. Very few of them have very deep experience in that, right? And part of that is you look at the kind of the most common treatment scenarios, and it's generally working in some kind of a center. It's seeing typically kind of younger kids with autism. It's primarily focused on treating some of the core symptoms, especially language deficits, communication deficits. And so that's where a lot of their training is coming from, and that's really where their emphasis tends to be. Whereas the experience doing some of the types of interventions I'm describing is much, much more rare. Really, there's a handful of places where people, even with behavioral training, are getting deep experience in addressing challenging behaviors. And so it's unfortunate because folks may have some kind of book learning when it comes to doing this work, but maybe don't have some of the real getting their hands dirty, doing this work on a daily basis and that type of experience. And so my biggest piece of advice is to really get clear with your provider. Is this something that they know about? Is this something that they have experience doing? And especially the types of experiences around some of the more significant challenging behaviors. One kind of little trick that I tend to use is, do they have experience doing something called a functional analysis? Now, they don't actually need to do a functional analysis every time, and they may not actually need to do a functional analysis with your child. But if they've never done one, then they may not really have much experience actually treating challenging behavior. Functional analysis is a process that we use here, again, for these really challenging cases where that process of identifying the function of behavior is really critically important. And it is something that is a skill or a assessment methodology that's pretty in-depth and requires some real experience to do it. And you should be clear too that there's a distinction between functional assessment and functional analysis. A functional analysis is a type of functional assessment that is a little more rigorous and a little more systematic. And so if they say, I've never done a functional analysis before, again, doesn't mean that they need to do that in this instance, but I'm at least starting to wonder, well, how much experience do you really have trying to address these kinds of behaviors? And is there someone else on your team maybe who does have that type of experience? So I hope that's helpful, because it is a big issue and it's something that isn't universally the case. People kind of see, well, this person, there's behavior right in their title. I need help with behavior. These things seem like they should go together, and it's just not necessarily the case.
No, that's really helpful. And I think it gives at least some terminology that families, caregivers, others can use to inquire with their interventionist as to their expertise, and perhaps even encourage them to maybe read a little bit about functional analysis or the data that your team has put out there. Kind of pivoting a little bit, but still focusing on this idea of functional analysis and utilizing that to evoke or to better understand sort of the reason why behaviors are occurring. We do have a question from our audience from Jennifer Bowler, who noted that you touched on pica and sort of functional analysis of determining what evokes the behavior from developing a controlled environment in your talk, or developing these, what I found very neat sort of ways of creating food out of different sort of items or edible items. What have you found related to maybe pica specifically?
Yeah, so functional analyses of pica are, you kind of think about functional analysis itself as a kind of a less common methodology that a lot of folks aren't very experienced in. Functional analyses of pica is even more so a kind of niche area. And part of that is because in a typical functional analysis, you're intentionally evoking a behavior to see what are the environmental kind of triggers or things that will cause that behavior to occur. And you're allowing the behavior to occur. Well, like I just said, pica can be life-threatening. And so you can't really just let, I have kids a girl who swallowed magnets, right? And I remember them saying, we have this kid who swallows magnets, will you help? And I said, magnets, sure, like you're not supposed to swallow those, but it's not particularly toxic. Like she was hospitalized at the time. And they said, no, magnets themselves aren't very dangerous, but when you swallow 38 of them at once, they tend to work their way towards each other in her intestines. They've caused perforations and took 6 hours of surgery to get them out. So like, we can't just put her in a room with a bunch of magnets and see what happens, right? And so, as I think you mentioned in the talk, I bring up how we use what we call the pica cookbook, which is essentially a way of identifying things that look like food that are not actually, or that look like non-food items but are safe to consume. And so we use things like there are certain starches that look like gravel, and there's little seaweed that looks like string. And I mentioned we kind of go to Asian grocery stores a lot because that's where you find a lot of this stuff. And you kind of bait the room and try to see what happens and see when the behavior occurs. And so that was the process that was followed for quite a while. And it kind of built on that literature where there's those 3 kids at a time. But what was interesting was once we looked at a larger sample than had ever been studied when it came to these types of treatments, one of the things that we learned was 100% of the kids, the pica served the same function. And so, I mean, in fact, for those kids, what we found was that the pica did not seem to be sensitive to any other kind of environmental consequence, right? It wasn't occurring to get attention. It was never occurring to get access to a preferred thing. It was never occurring to get out of anything. Some of the more common consequences that we see maintain behavior, it seemed to be insensitive to anything else going on around them. We tend to conclude that behavior serves what we call an automatic function, which just means that the behavior automatically produces the consequence. Oftentimes we think of that as more stimulatory. So these were individuals who kind of explored their world by putting stuff in their mouth. They oftentimes swallow the things that went into their mouth. And because we identified through this larger study that seemed to be the case 100% of the time, we've actually changed the way that we practice. We don't necessarily do a functional analysis for pica anymore. We know how, but we'll bring them in and we'll initially do a quick screener just to confirm, yep, this is maintained by automatic reinforcement. Let's skip all the other analysis that might go into this that would take us days and days to do, save ourselves a bunch of time and start the actual treatment process much more rapidly. So I hope that answers Jennifer's question around how you go about doing some of that and some of the findings around pica and functional analysis.
Yeah, no, that's great. And it also shows how you can tailor then your approach of evaluating your assessment and the treatment and what you're doing around a specific behavior. Going back a little bit to what you spoke about ABA, we have a question from our own Dr. Buchheimer, who said, you mentioned that ABA does have some gaps in what it might be able to address. Where or what do you think are the areas where ABA has perhaps failed, and what intervention approaches might fill some of these gaps?
Yeah, so I think, again, kind of hitting on some of the themes, I'm trying to tie it all together. Go to the theme I had earlier as far as look at some of the roots of behavior analysis and where it comes from. And I mentioned that a real focus is on directly observable behavior. And that was a reaction to kind of where psychology was in the previous century and relying a lot on self-reports and whatnot. And so folks said, well, we want to focus on what we can see. And so that continues to this day to be a real foundational principle of behavior analysis, just to focus on directly observable behavior. Well, what that has translated to from an intervention standpoint is that the field tends to focus on those kinds of behaviors and also, well, behaviors that are easily measured through direct observation. So when you look at how folks treat kids who work with kids who have autism, who come from that ABA perspective, they tend to focus on the things that are easy to measure directly. Things like language. So you'll see a lot of folks working on communication skills, and there's great outcomes for many of those kids with those types of approaches at increasing language, increasing functional language, and so forth. But what we know about autism is that so much of it is actually rooted in the social elements of behavior and how these folks relate to the world and the people around them. It's really hard to measure some of those critically important variables that really are fundamental underlying factors that cause autism. And behavior analysis just hasn't done a great job at dealing with that. And again, I think that's largely because it's really hard to measure some of that stuff. I don't think it's necessarily impossible, but it's just when there's lots to work on and there's the kid who is not, who is minimally verbal, it makes a ton of sense to focus on language. And so that's where the field has tended to focus. And I think to the neglect of other facets of autism that are at least as important when it comes to especially closing the gap in those underlying constructs that then manifest as language difficulties and or social communication difficulties and rigidity and so forth.
No, thank you. Another question from the audience, from Doreen Samuelson. What is your suggestion for a BCBA who wants to get specialized training in challenging behaviors? She notes that interacts with a lot of BCBAs who have very little experience. And as you noted, this is a major problem. So what perhaps are some suggestions for training?
Yeah, it is a big gap in the training. And there, the good news is that the groups that credential or certified behavior analysts recognize that to be the case. And I think as we see, as I mentioned, the ABA is a relatively new profession. When it was brand new, you set the standard, you set the expectations too high as far as how much coursework and how much experience people have to get, then you can't get anybody into the pool of providers to begin with. And so in talking to some of the folks who organize and run things like the Behavior Analysis Certification Board, it's really clear that every year they ratchet up one of the criteria. They make the test harder. They make the coursework requirements more stringent. They make the experience requirements higher. And so each year they're increasing the standards in one way or another. And what you're starting to see is an increase in recognition that this is a gap in a lot of folks' training and that they need to get greater experience. Another thing that you're starting to see is as part of a conversation that was hosted by Autism Speaks for the kinds of the handful of programs around the country who do this type of work at a high level. And there was a conversation about, do we need to actually have specialization, that people could actually specialize in challenging behavior so that it's clear to people in the community who might be consumers, this is somebody who actually can help my kid. And maybe someone else could say like, that's not my challenge that I'm dealing with. And so someone else might be an effective clinician for them. So I think those are a couple of things that are already underway that I hope will be helpful with this. In the meantime, in terms of getting this specific kind of experience, it is a real gap. And I think that, our center, one of the things that we've tried to do is we started a thing we call a severe behavior boot camp. We actually will have folks come and they can spend 3 weeks with us. And in 3 weeks, it really is a boot camp. And they spend time learning how to take data. They run sessions, they get trained in how do you physically manage somebody trying to choke you out, right? Like all those things, stay safe and not use restraints and keep the individual safe and de-escalate. We teach them how to do some of this via telehealth. We do a lot of this work via telehealth. So they sit in on a telehealth visit in shadow. They run a case of their own. So they actually they have a case, they work with that child, they conduct the functional analysis, they develop the intervention, they train the caregivers, all of that within a really condensed time frame. And we've had folks from all over the world come and visit. We had a group from Russia a year and a half ago. We'll see if anybody from Russia is welcome in the United States anytime soon, but we had folks from Korea and Kazakhstan, Australia, throughout the world and throughout the United States to come to get some of that more intense experience without necessarily having to go take an entire semester's worth of coursework or do something that isn't really feasible. And then the other piece of that is extending expertise through technology. Like we said, we wrote a grant recently with some colleagues at Rush University around this idea of how do we disseminate expertise so that folks don't have to live near a center like ours in Atlanta. They can actually get some of that expertise through coaching. So if they have providers in their institution who work with folks with autism with challenging behavior, could providers at our center actually support some of them so that they can be able to operate at a higher level and conduct assessments, analyses, and interventions at a higher level than they could without that type of support.
Oh, that's great. And so speaking kind of in the realm also of telehealth, and I've asked you now, how can you translate from your center to an ABA specialist, and maybe now from a telehealth perspective? Obviously, in the era of COVID and likely beyond, teleintervention has been widely used. Have you been able to, your team, utilize functional analysis successfully through telehealth? And in addition to that, just expand, are there tips that you have or sort of things that your team has come up with for interventionists to maximize telehealth interventions?
Yeah, so telehealth is interesting, especially in this time of COVID. Interestingly, we had, I was a principal investigator for an NIH-funded study specifically looking at telehealth and doing clinic to home-based telehealth to treat challenging behaviors. And our outcomes were really good. And the initial paper, which was titled something like Challenges that Frequently Occur When Delivering Clinic to Home-Based Telehealth, that paper came out in April of last year. So like right as COVID was hitting. I mean, I swear, I wasn't like encouraging people to eat bats or spreading COVID or anything like that, but boy, was it timely, right? I mean, it came out just in the nick of time. And in fact, because we had a lot of experience delivering these services via telehealth, when we made the decision on, I remember it was a Thursday and we were kind of in the throes of making decisions about COVID and who could we continue to see at our facility and what services needed to be discontinued. That was on a Thursday, and by Tuesday, we had transitioned all of our cases to telehealth. It was literally just flipping a switch because we'd done that study. We already had all our consents in order. We had all the documentation. We knew how to help a family get their phone set up to do this. We knew how to schedule appointments. And so within the first 2 months of COVID, our center had done more telehealth visits than the rest of our children's hospital put together. So the answer is absolutely, this can be done via telehealth. The only caveat to that is for those really severe behaviors. We were already doing a lot of in-home services to try to address challenging behavior and really there's some true advantages. Seeing the behavior in the setting where it's occurring, it's much more applicable. You don't have to generalize treatments back into that setting. We know that when we generalize treatments, there's often a relapse effect that we have to work through. So all things being equal, better to do it in the home than to do it in the clinic to begin with. For behaviors that are particularly dangerous though, pica being one of them, severe forms of aggression or self-injury, elopement, these are behaviors that can be very dangerous. And we also know that when we start treatment, often things escalate before they get better. And so even if it's kind of on the edge of being dangerous, we will defer and see those kids within our facility just to maintain safety, if for no other reason. And so that really is where the limits of telehealth, kind of the boundaries of telehealth lie. But beyond that, we find that you can treat oftentimes behaviors that are more severe than you might think in the home with the right kinds of coaching and the right kind of supports.
No, that's really helpful. Thank you. I know we just have a couple of minutes. And so one, I think you're going to get a lot of inquiries on your center and opportunities just from the questions that are coming in for training. But I'll kind of mix a few questions together where individuals have asked about providing intervention for problem behaviors for older kids. So older kids, and also in the realm of what questions have described as high functioning, but I'll say without intellectual disability or who are verbal. Have you found that your approaches are still beneficial for those kids when they're older, and how so?
So I would say age is not necessarily all that critical when it comes to developing these interventions. I've worked with individuals from 18 months of age to 92. And seen similar levels of success, regardless of age. Now, obviously, the longer an individual has a history of behavior kind of functioning for them in a particular way. So if somebody has 92 years of them getting, preferred items whenever they hit people, that's a lot of momentum, if you will, behind that behavior that's really can be challenging to reverse course. And so obviously, the earlier we see someone, the better. at our center now, we're part of the Department of Pediatrics, and so we focus on kids, but there's nothing specific to childhood. It's not like at 18 or 21, suddenly these things stop working. Now, what I will say is the other part of the question, which is for those individuals who maybe don't have any intellectual disability, that's where there do tend to be some limits in terms of how successful these strategies can be. I sometimes tell folks, like, I would much prefer to work with someone who, I take iPad, you punch face. Like, that's pretty straightforward from my standpoint. Maybe I get punched in the face once, but after that, first, I know you're coming. Second of all, I know what's going on. This is about the iPad, and I can, it can teach you a more appropriate way to request the iPad, and we can teach you to wait for the iPad after you've learned that request. And there's a lot of strategies that can be really effective. It's those folks who, I take iPad, you wait till tomorrow when I'm not looking and punch me in the back of the head. That'll teach me for taking your iPad. That's a much more challenging dynamic. And I don't know that there's the same level of success. There are still strategies that can be effective, but they generally need to be supplemented with other approaches, more CBT type approaches, cognitive behavior therapy, or other types of approaches that are kind of getting at some of these other, verbally mediated, I guess you would say, aspects of the behavior. And just straight behavior analysis probably can make a difference, but you're going to tend to have to rely more so on really potent reinforcers. And oftentimes those things are more likely to change. So things like token economies and the like can be helpful, but I would say need to be supplemented.
Well, thank you so much, Dr. Call. That was excellent. It was so informative and beneficial. Thank you, everyone, for your questions from the audience. And we look forward to hearing from you more in the future. Thank you, Dr. Call.
Oh, it's my pleasure. It's good to see you again. I always enjoy partnering with UCLA and the team there. And CART is really an amazing. Dr. Geschwin hit it on the head when he talked about just how the culture of that team is really something to be envied. So it's always my pleasure, and I hope to have the chance to do this again sometime.
Thanks so much, Nathan. Thank you so much, really. And that was both you and Rajuta. Thank you so much for that. The next keynote speaker is Dr. Kathy Lord, who has been with us at UCLA for the last, I guess it's almost 3 years now, discussing her talk on autism assessments during social distancing. And this will be moderated by Dr. Ben Snyder. I'm giving the floor over to you, Ben. Thank you.
Good morning. It's really a pleasure to introduce Dr. Lord. Dr. Catherine Lord is the George Tarjan Distinguished Professor of Psychiatry in the David Geffen School of Medicine at UCLA. She's a practicing clinical psychologist whose primary focus is autism and related disorders across the lifespan, from toddlers through adulthood. Her research and clinical work are aimed at improving methods of identifying strengths and difficulties in individuals with possible ASD and working with families and individuals to maximize independence and well-being for all concerned. This has involved the development of diagnostic instruments like the Autism Diagnostic Observation Schedule, the ADOS, and the Autism Diagnostic Interview Revised, the ADIR, the Social Communication Questionnaire, SCQ, that describe individual profiles of skills and weaknesses and carrying out longitudinal studies from age 15 months up to 30 years with the goal of identifying protective and risk factors that influence milestones of progress over the years. A current priority is to develop better ways of measuring changes in social behavior and communication over short periods of time that can be used to monitor progress without bias. And another priority has been to participate in large-scale studies where researchers share data about both behavior and neurobiology. This has included the Simon Simplex Collection, a genetics consortium led by geneticists and researchers through the Simons Foundation, Abide, an imaging open science group originated out of NYU, and the Healthy Brain Network through the Child Mind Institute, as well as numerous clinical trials of different interventions. She's also very interested in graduate training for psychologists and other clinical researchers in ASD and related fields. She's a member of the National Academy of Medicine and a fellow of the American Association of Arts and Sciences, as well as a former chair of a National Academy of Sciences Committee on the Effectiveness of Early Intervention in ASD, a co-chair of the New York Board of Health Committee on ASD, and a member of the DSM-5 American Psychiatry Association's Neurodevelopmental Disorders Committee. She is the recipient of numerous awards, including the Lifetime Achievement Award from the International Society for Autism Research. She has over 300 referred journal publications and has been funded by the NIH, Autism Speaks, and the Simons Foundation for numerous research grants. Whew, that's a lot. Dr. Lord, if you might, please give us the TED version of your talk, a 5-minute version of your talk, and then we'll get started with the Q&A.
All right, you guys. Hi, everybody. It's very nice to be talking to you, if not seeing you, and at least I get to see Dr. Snyder. I'm going to give you the hopefully 5-minute version of my talk. And I think what I want to do is really make 3 major points. One is that I think the opportunity or the need to do social distancing gives us a chance to really think about what are we trying to accomplish in an assessment of a child or an adult where someone is wondering about autism. And I think there really are 3 different things that we want to do. And often we get very focused on one of them, which is very important, which is to come up with a formal diagnosis, which I do think is an important part of an assessment for a whole lot of reasons. Probably most important because it is a ticket to services at the regional center, insurance, access to various things, but it also opens up information that we've gathered for many, many years about other people with autism that can be useful for a particular individual. A second thing, though, is working with parents and helping them begin to understand what it is that is not going well for their child and also their child's strengths. And that means not just things about autism, but also information about co-occurring disorders, ADHD, anxiety, language delay, intellectual disability. And that factor is really, in some ways, antithetical to the need for a very quick formal diagnosis. And the third factor is monitoring. We need to do a better job of keeping track of how kids change over time and adults. And we can do that, but you can't do it if you don't measure something that you can then go back to. So in my long talk, I really talked about 2 different instruments that we've been working on during this time. One is the BOSA, which stands for Brief Observation of Symptoms of Autism. And this was our attempt after being flooded with questions about, can I do an ADOS remotely? Can I do an ADOS with both of us masks? In which we've said, really, no. You can certainly use tasks from the ADOS, but you can't score it and add it up and get a CSS because too many things are different. So we came up with about a 10 to 15 minute series of tasks that we can ask parents to do at home or in a clinic so they can be unmasked. You could actually also ask therapists if a therapist is in the child's pod to do it with them. And it's easy enough and clear enough so they can do it. And then you score it using ADOS items, which are then reduced to binary scores of yes, I saw something unusual, or no, I didn't. It doesn't mean it's not there if you didn't see it. It just means you didn't see it. We have been analyzing data for the BOSA now for the last year, and actually the sensitivity looks pretty good. It really looks like we can identify probably about 90 or sometimes closer to 95% of kids we think are autistic. And actually also adults. However, we haven't really measured specificity. We can't tell how well we can rule out people that don't have autism. The data we have suggests it's certainly not as good as an ADOS. It may be in some cases about 70%. So you're going to end up with scores that are like a person with autism in a substantial minority of kids who we don't think have autism. What this has given us is an opportunity to see parents interact with kids, not in a very natural way, but it's a start. You can do this at home. We've been literally mailing out kits to kids who are in various research projects or they need a formal diagnosis. So those have been real strengths, and it's fast. The disadvantage is parents can't watch this because they're doing this, and they're sort of doing this under the gun. And the other thing I think people who do a lot of ADOSs are struck by is it doesn't give you a chance, nearly as good a chance to see strengths. The ADOS is really organized to try to catch the child at their best as much as you can. And then if you need it, provide support. And that is, the BOSA does not do that. On the other hand, it can, we hope, give you a reasonable sort of screening diagnosis that goes beyond the checklist that we use currently. The second instrument I described is the BOSC, which is the Brief Observation of Social Communication Change. And it is a measure of change. So the number that you get for a child does not mean anything, except in the context if I'm going to do this again after a treatment that might last 3 months or 4 months or 6 months. And then you look at the change. And this also can be done at home. It's going to be a standardized measure. So the idea is to have something that crosses different interventions. It's not specific to ESDM or JASPER or ESI or Project Impact. It's across measures, and it takes away the bias of parent report, because particularly in psychosocial trials, parents are quite aware of what they were in and what they weren't in. We hope it will be sensitive to change. It looks like, at least for minimally verbal kids, in some interventions, we can see very nice changes that are bigger than what we would see in a control group. But we don't know yet. So that's the other thing that we've been trying to do. And again, it can be done at home. So I think I'm ready for questions, Dr. Snyder.
Thanks. There are several of them already, so let's launch right in. Dr. Lord, how might you account for parental pathology in using these measures? For example, in inherited ASD, presumably one parent may themselves have signs or symptoms of ASD. Have you quantified the difference between two BOSAs, one where the kid is interacting with a symptomatic parent and one with the parent who is not?
We have not for the BOSA. So I think you have to be very careful. I mean, the BOSA is not going to be the end all of anything. It's a start. And I think you would need to be very careful if you see parents who are, I mean, there's every extreme. There are parents who are phenomenal at getting the best out of their child, even though you've just said, please act relaxed and don't try to bring out the best. And there are other parents who are really struggling. So that's a very important limitation. With the BOSC, which is the measure of change, what we have been able to do is we have a separate coding system for what parents are doing that basically took the main principles that parent-mediated treatments are trying to teach. And you can code those. And we can say to you, absolutely, that the more of those a parent uses, the better the child looks. But we think that's probably a good thing because you can control it. You know, if the parent is improving and the child is improving, then that's good. The other thing is that we would recommend for the BOSC that you do both parent BOSCs, where the child interacts with the parent, and with a therapist. And ideally the therapist, sorry, it shouldn't even be a therapist, an examiner who doesn't know what you're looking for, who is really, you know, pretty much a babysitter in there, bringing them in. And so you can see if it generalizes, but that's a good question.
We have a series of questions, actually several questions about diagnostic assessment in general. At the ACAP Autism Institute, Dr. Joshi offered his contention that we should rely solely on clinical screening and DSM symptom inventory in autism diagnosis. He argued that autism diagnostic interviews and observation schedules require expensive, time-consuming, and not readily available training, and that assessments are expensive, time-consuming, and with limited accessibility and have questionable sensitivity to detect ASD in high-functioning and adult populations, and questionable validity in populations with emotional and behavioral problems. Can you untangle us from this web of differing opinion?
Yeah, I mean, I was on a panel with him and was pre that talk and was struck by how little he knew about what actually happens in a decent assessment. So I think, I mean, there are limitations, there's no doubt. I think it actually works. I mean, the data with adults is really quite strong. It's not perfect. Nothing is perfect. But I think part of it is asking, what does it take? What time does it take away? I mean, the reality is, we see families all the time who are coming to us to learn about their children. And this is an opportunity for them to learn about their kids. We also see adults who want to know about themselves and to share that knowledge. And that is what you're doing. You know, when you're doing an ADI, which is long, I mean, we're working on a shorter version, you are learning about the family, learning about the kid, so that you can say, all right, they have autism. What are we going to do next? And the reality is that label of autism is one particular bit of information. It is not everything. And to just stamp someone as autistic does not tell you much of anything, because there's so much heterogeneity. So I don't think it's wasted time. I also think the reality is there are probably more people trained to do the ADOS than there are developmental behavioral pediatricians, and probably than child psychiatrists who are skilled in working with autism. So it's not, I think it's just annoying, particularly for physicians who feel like, I can do this. I can say they're autistic. You probably can, probably, 80% of the time. A good skilled physician could identify autism without anything, but you can't work with a family in a clinic room in a 30-minute visit and do all the other things that you need to do, I don't think. And so I think he shouldn't be telling us, I mean, he can't do it. He should do what he's good at, and we should do what we're good at. And I don't quite understand why there's this either or, because it's just, I think it's an inconvenience for people who are in a hurry or want to compete with this, but it gives you a different kind of information.
Such a good point. And Dr. Lord, in your talk, you mentioned the dangers of a potential two-tiered system, and especially in given the social justice concerns, and worsening for potentially what already seems to be a two-tiered system. In your longitudinal work, can you comment on some of the problems you've seen arise from a rushed diagnosis?
Well, in our longitudinal work, the kids have gotten, because they're in our research project, they've all gotten more diagnoses than they need. But I think the point of that is that almost every child we see got a rushed diagnosis already somewhere, and they are then coming for something else. And so I think what worries me is that if what we are offering, and places already do this, for kids who are on Medicaid, they get one system. Families who have insurance get another. Families that are willing to pay out of their pocket get another. And even in places like Canada, this happens. And I think it's really of concern. I think the second issue is that the diagnosis is so much more than a label of autism. It's a label of autism does not tell you what treatment to do or what, and the reality is the people who are going to be in charge of that treatment or deciding that treatment is the family. It is not us. And the family is going to deal with a child or an adult who is changing. And so we need to recognize that we want to give information and work with people to help them navigate this whole process.
I want to switch gears for just a second because I have an informal rule that if I see a question arise 3 times in a row, it means it's really important. So I'm just going to choose one of them here. I've been really glad to have the BOSA as an option during this time, but at the same time, I'm finding it really challenging to get a good sense of more complex borderline cases in the 15 minutes of the BOSA. Any suggestions for these less clear cases?
I mean, you're absolutely right. I think there are times when it is just not enough. And what we've been doing is we actually have been going back and in masks doing ADOSs, and then not necessarily scoring it, but at least using the breadth of the task. And I think that's fine if you have to. We've also just been trying to observe. We've had parents, I mean, we're doing a combination of not quite ASD peds, but having parents sometimes send us videos of things. But you're right. I mean, we've definitely had complex cases where after 15 minutes, I don't know, you're just getting started. So it's not going to replace an ADOS, but I think you should do anything you can to get more information from the family and from the young person to see if you can help it and not just stick to the BOSA.
Keeping with the BOSA for just a few more minutes, you mentioned that families can see a video beforehand of what exactly they're going to do. Is there any thought about making this part of the standard practice, and where can the videos be found?
The videos are available through our training, and I think there's a website, and I don't remember what it is, but we can get it for you. Oh, here's somebody who's probably texting me with it. But the video, we really don't act out the whole thing because we don't want families to think this is what the way we want you to behave. But we basically show them, here, you put this here, you put this here, you're going to do this for 4 minutes, this for 2 minutes, you know. So it's just trying to make it as clear as possible. I don't know what will happen to the BOSA next. I mean, I think if people want to use it, we were really lucky that WPS, who basically owns everything that I've ever done, let us release this for free. And it does require scoring on ADOS protocols. So they have that interest, but I don't know how long that will continue, but we just wanted to jump in here. So hopefully it will be a start. I mean, there certainly are contexts where it can be really helpful to be able to just see a family interact with a child for 15 minutes, and you can say, absolutely, this is autism, or very unlikely. But again, it's not, I don't think it's going to be the answer. And the specificity may be really not good. I don't know.
Well, before I ask this next question or series of questions, I'll put in my personal plug that I hope that that won't go on for too much longer, that we even have to have this kind of discussion. But we have several questions, Dr. Lord, that have come in about administering assessments masked. The ADOS mask just for not scoring, but just for observational purposes. And then also we have one question about whether or not, what are your thoughts on using a clear mask and face shield to deliver the ADOS to?
I don't think the clear mask is not good enough. I mean, it's just still too weird. So I think you got to remember that there's just different places on your face for the kid to look at. It changes the degree to which they can hear you to some degree. It is not enough. I mean, you can certainly do it. You can do anything. But I think that you just then have to use it within clinical judgment and don't add up your numbers. Just resist the temptation to treat this like a standardized measure. I think we definitely have just got to the point with BOSIS where we're like, I don't know if this 12-year-old girl with high anxiety it was really smart, has ASD or not after watching her for 15 minutes. And so then we are basically doing ADOSs with masks. But then what we're reporting is a clinical diagnosis. And I think that's fine.
Thanks, Dr. Lord. I'm going to switch gears for just a few minutes and move over to the BOSC. Can you talk a little bit about how many groups are currently using the BOSC and why?
Well, I was surprised when we checked with WPS that they said there are about 40 groups that have applied to use the BOSC. I had no idea there were that many. I think that there are really two streams. WPS will not let anybody use it unless it's for research, but there's really two aspects. Pharma is quite interested in it. And then, well, there's three. Pharma, I think psychosocial studies. So like there's the PRT study from Stanford. There's groups in Germany who are using it, groups in the UK, groups in the US. And then I think the third group is some of the recent ABA agencies are very interested in having some kind of standard measure that they can use with pretty much everybody. And so that's another group that is more clinical, but we hope it will be able to be used in pre and post research. It's an unknown. We have nice data from minimally verbal kids that showed nice changes in kids who were in, relatively intense early interventions, and more change in kids who were interventions than not. But the version for kids who have phrase speech and young fluent speakers is just being finished. So we'll be able to tell you more about that really, hopefully in the next few weeks. It also looks like it's good. Using it here in one of the UCLA clinics at Kids Connect, the kids have had beautiful progress, which has been lovely to see. We don't have a control group though because of COVID. So I think that's going to be an issue, is we've got to get controls before we can make very many more statements. And then we're almost ready with online coding. It still involves a human being using the online program, but at least we hope that will make it easier to send tapes back and forth and have data entered immediately. So it's coming along, but it's new. And I think that I certainly wouldn't recommend using it but it's worth a try. I mean, what it does take away is just the bias of therapists or parents, which at least for me as a clinician, I am biased as hard as I try not to be. And so we hope that we can add that element.
Several questions that are kind of coming in a flurry now about the BOSC. Can you comment, Dr. Lord, on the benefits of using a tool like the BOSC to assess progress? And if I can add also, I wonder if you can comment on how meaningful it might have been for the parents in the Kids Connect program to see the progress firsthand by using something like the BOSC, or if they were involved.
They haven't been involved yet, but that's the idea. I mean, that's where we'd like to go. In my ridiculous fantasy is that someday we get automated coding, so it's very cheap and easy. But even now, you could have somebody in someplace like Kids Connect, and you do these every month, and you upload them. Someone who doesn't know you scores them, gives you back the numbers. Once you have a pre-treatment, then you can always compare the next one. You know, the number in itself doesn't mean anything, but it's the change. So you could provide parents with literally a graph of this is what's happening to your child in these behaviors. And again, remember, it's the kind of thing you can measure in a 10 to 15 minute, so relatively natural social interaction. So we're talking about sharing, giving, taking turns, eye contact, facial expression, gestures. And then as kids get older, we're talking about more sophisticated ways of attending, sharing enjoyment, but in a situation that's not the same as the therapy.
Thank you. There are some organizational pushes to continue to do virtual assessments in perpetuity. What are your feelings about the integrity and utility of continuing to do virtual as opposed to in-person assessments once it's possible to bring people back into the clinic?
I think it's really hard to do a completely virtual assessment. So, but I think that it's much of what we can do can be virtual. I mean, certainly parent interviews and feedback can be virtual. I would hate to be pushed to do everything virtual unless you absolutely have to. I mean, unless you're dealing with somebody who is really far away and just cannot get to you. But I really hope we are basically insurance allows us, and our hospitals allow us to continue to do some things virtually because we can save a lot of time and back and forth. But I mean, the scary thing is just, I think, as you said, Dr. Snyder, that, are we going to be pushed in one way or another? Like we either can't have them or everything has to be virtual. And I think we need options, because sometimes you just need to see a child, or an adult in person.
I think I'm getting a 2-minute warning, so we have time, unfortunately, I think, for only 1 or 2 more questions. Was there anything about your analysis that surprised you or your team? Was it easier or harder to find things that, quote unquote, hung together?
I think we were very naive in thinking about, particularly the BOSC with older kids, thinking that we would see changes in basic social behavior the way we do in little kids. So we were really horrified when we applied the things that had worked well with young kids and minimally verbal kids to older kids, and they're not like smiling more, no. But you think about doing an interaction for 10 minutes with a 13-year-old who's might have autism, and they're not necessarily thrilled to see you. So I think we really had to step back and say, look, what do the treatments do? And what are we talking about if we really have natural interactions here and not something that's really very set up to make them happy?
Well, I'll give you one more, because I think there are a lot of folks on this line right now who are very interested in this. How long before you think the BOSC will be more readily available?
Yeah, it's getting there. I think we're hoping that Minimally verbal is really available now, but the trouble is we're asking people to let us score it until we're sure the online system works. I would say hopefully over the summer that would be true. And then what we will be able to do is license the whole thing to you so that you just pay to have this uploaded, not like Noldus. This is not going to be expensive, but something that you can do yourself. So I would say for minimally verbal kids, the end of summer, and maybe for phrase speech kids too. For people who are more verbal, we're madly collecting data now from anybody who will give it to us. And so that's probably going to go into fall before we really have enough data to be sure that this does show change. But just keep in touch with us. We will set up a list and we will try to let you know as soon as we know.
Thank you, Dr. Lord.
Okay. Thank you.
Thanks really to both of you. Thanks to Ben for really beautiful job handling all those questions and moderating, and Kathy for for spending the time with us to answer all those questions, as well as all the work you've been doing on the back end to develop these tools and help the field move forward during this very challenging time. So really, I'm grateful to both of you. And now it's my pleasure to call for a 10-minute break that I'm sure we can all use. And we're going to start exactly at 10:25. So follow your computers and iPhones. See you soon. I'm giving everybody a 2-minute warning. See you back in 2 minutes. Hello, everybody. I'm assuming we're back, and I want to introduce our next session. In this panel, I'll actually join in our discussion about genetics with our guest speaker, Dr. Allison Barrett, who is hard for me to categorize. I don't know her personally, but after listening to her talk, one would have to say that although she is a parent advocate, I think that has to be in all capitals with multiple exclamation points. So it's really a great privilege for me to be on here with her. I know Shefali is going to introduce her. Dr. Shefali Jesti is going to moderate this panel and we'll introduce it. But I do want to say, I think Dr. Barrett and her colleagues have done more in the last 5 to 7 years than is almost imaginable. So anyway, I'm looking forward to this panel.
Great. And thank you both for joining and for all the audience members. Our format was a little bit atypical today, and we did that on purpose. So we really would have time for discussion. So I really am excited about this pairing. It actually is really, I think emblematic of precision health and the promise of translational science to have Allison and Dan, Drs. Barrett and Dr. Geschwin on this panel. It's a researcher who's really led the field in discovering the genetic underpinnings of neurodevelopmental disorders, and then a parent who's taken many of those insights and translated actually into a treatment. So I would say it's like the embodiment of what our goal is, right, in precision health. So I'm going to quickly, what we're going to do in this session, we have a little longer since there's 2 of you, we have 45 minutes. So I'm going to quickly introduce each of our speakers and then allow each of you to spend 3 to 5 minutes, just as Dr. Lord did, just to give a quick summary of your talk in case there are people in the audience who did not get a chance to watch. And again, I would really, really encourage all the audience members to go back after this and watch the talks if you have not. And then once you've done that, I'll ask some questions. We have a few that have already been generated from the audience, and I'm sure many more that will keep coming in. So we'll start. So I'm going to first introduce Dr. Daniel Geschwind, who really does not need introduction, I would say. He's really our fearless leader here in CART. He's the Gordon and Virginia McDonald Distinguished Professor of Human Genetics, Neurology, and Psychiatry at UCLA. In his capacity as Senior Associate Dean and Associate Vice Chancellor of Precision Health, he leads an Institute of Precision Health here at UCLA, where he really oversees campus precision health initiatives, and you heard about some of those in his talk. He founded UCLA CART, our Autism Center, with Dr. Marion Sigmund in 2003. And this center really has led the world in understanding mechanisms underlying autism and designing, studies and intervention over the decades. His research is really focused on understanding genetic mechanisms of autism. And his lab has pioneered the applications of systems biology methods in neurological and psychiatric disease, and particularly in autism, but in other areas as well. It would take us 45 minutes talk about his awards, so I'll mention a few. He received the Scientific Service Award from Autism Speaks, the Gold Medal Award from the Society for Biological Society or Science, and importantly, he's an elected member of the National Academy of Medicine. I just want to mention that his accomplishments, again, his CV is probably 5,000 pages, but more importantly, I think Dr. Geschwind, about him is that he's such a generous mentor, colleague, and collaborator, and his work, and he talked about it a little bit in his talk for the symposium, but he's really prioritized finding ways to work synergistically across disciplines and to build opportunities to harmonize data and to really collaborate across groups so that we can answer questions in this complex area of neurodevelopmental disorders adequately and effectively. He started AGREE, which is the Autism Genetic Research Exchange, and that really transformed the field in terms of autism genetics. And many other groups are trying to really emulate that now. So I just want to emphasize that, many of his accomplishments and go beyond his CV. So I'm going to move over now to introduce quickly Dr. Alison Berendt. And again, impossible to introduce her quickly, but I'll try. So she's the Director of Interventional Endoscopy Services at the Animal Medical Center in New York City. So she's a veterinarian, but also she's the Board of Directors and the Scientific Director for the Foundation for Angelman Syndrome Therapeutics, and then the CSO of FAST as well. So she's, again, a veterinarian whose work is really specialized in interventional endoscopy. But importantly for this session, in 2014, her daughter was diagnosed with a rare neurogenetic syndrome called Angelman syndrome. Very quickly thereafter, she joined the board of directors as the scientific director for FAST, Foundation for Angelman Syndrome Therapeutics. And in March of 2016, she became their chief science officer. And she really helped to spearhead the development of a pre-competitive biomarker and outcome measure consortium as well to bring patient-focused outcome measures forward for human clinical trials, particularly in Angelman. And so actually she will talk about her journey more, but her work has really led to a current clinical trial in Angelman syndrome for an antisense oligonucleotide. UCLA is a site for that trial, and it's already launched actually in several places around the world. So she really is the kind of paradigm of parent advocate. So with that, I'm going to just stop and ask each of you, we'll start with Dr. Geschwind, to give a short summary of your presentation, and then we'll move it over to Dr. Berendt before we ask questions.
So basically, the summary goes as follows. Identifying the cause or causes of a disorder is extremely important in getting the proper therapy, not just in brain disorders and neuropsychiatric conditions, but across biomedicine. In my talk, I discuss ulcers, which were previously in the 60s, believe it or not, proposed to be due to domineering mothers, just like Bruno Bettelheim's 1960s thoughts about autism in The Empty Fortress. And so, fast forward, when I started in autism genetics, now about 22 years ago, there was very little known, but it was clear that it was highly heritable and there were likely to be genetic forms. Fragile X was one form that had about 20% of the kids with Fragile X had an autism diagnosis. So it was already known there were a bunch of medical genetic conditions, but it wasn't really appreciated that well. So the last 20 years has led to the identification of hundreds of autism risk genes, most of them rare mutations like Angelman syndrome that cause a panoply of neurodevelopmental symptoms, not just autism. So we've learned that there's no such thing as an autism gene, that these genes disrupt brain development, increasing susceptibility for a range of developmental disorders, including autism. That's one thing we've learned. But these genes provide a toehold for mechanistic investigation, because now we can explore in animal models and in stem cell models in a dish how these mutations might disrupt development or neural functioning, and then screen for therapies to alter them. And I think Dr. Berendt's Odyssey is a testament to that. And again, the work that she's going to talk about builds on decades of basic science research that's brought us to this point. Advances in technology are now so extraordinary that we really are living the promise of gene therapy, of genomic medicine, and we're on a cusp of a revolution there. So lastly, I'll say that, so while we've learned that autism is a collection of rare disorders in one sense, part of it, all these rare conditions, that it's not one thing. Autism should be called the autisms, which is a term that I've used to coin it. And that can be a problem because autism is also a spectrum from people who have very, very severe disabilities to those that really, are extraordinarily high functioning and have many, many strengths. And even those with disabilities have strengths. So I think one thing I'd like to get across, and it's not fundamentally related to the genetics per se, but that, many people who have a label, people are people, each person is an individual. And as physicians, we treat people as individuals when they're in our office, and we appreciate both the family issues and the personal issues that are going on. And so, a point I want to make is that one isn't necessarily defined by their genetics. Genetics is not deterministic. Genetics just gives you a toehold, and we can approach these genetic disorders using therapies, both behavioral and molecular. Those are environmental ways of modifying genetics. So I'll cut out there. That was probably too long, but
No, that's perfect. And Allison, and I want to emphasize the reason I didn't go through your entire bio is that in some ways your talk is your bio, right? And I also think I want to let you tell your story rather than me telling your story. So, but again, it's incredible. So go ahead.
I appreciate that. I was thinking to myself, how am I going to tell my talk in 5 minutes when it is my introduction ultimately? So I'm going to repeat a little bit of what you said, but first I'd like to start off by thanking you, Dr. Joshi, for inviting me to speak at this meeting today. I've heard you and Dr. Geschwin speak multiple times, and I'm the one who's humbled to be here. So I very much appreciate the warm welcome, but I really am the one who is most humbled to be a part of this, and I'm honored to share our story because it is a story to be shared. And I think it's a story that many other foundational groups and many other families will share eventually, or may have been able to share something like it. And if they are not anticipating it's something that they will share, they may think a little differently, hopefully, after they hear my talk or just hear a little bit of a background, because so many things are possible for kids, especially with syndromic autisms or genetically linked autisms or neurodevelopmental disorders. So let me start by saying I am a veterinarian. That is true. That is my day job. I am sitting in my veterinary office right now. And I do medical device development. So that's been my entire career. I design and develop medical devices for animals with naturally occurring diseases. And then we invent them, we utilize them, we do clinical trials, both my husband and I, we work together. And then we translate those medical devices for pediatric patients who there is a really clinical unmet need for pediatric patients requiring medical devices. And that's been my entire career. And then in 2014, my second daughter, Quincy, was diagnosed at 5 months of age with Angelman syndrome based off of developmental delay and an odyssey of being told there was nothing wrong with her and that she was completely fine, but on a different trajectory than my older daughter, who was neurotypical. And my husband and I, both being veterinarians and clinicians, we felt otherwise. And so we actually had to push for this discovery and this diagnosis, which is why we got the diagnosis so early. And so we were diagnosed at that time, and we really had a very hard time with the diagnosis, one in the way it was presented to us, which we can talk about, and in another in trying to understand it and understand what her options were. My husband and I both fix things. That's what we do. We design medical devices to fix problems. And Quincy had a problem, and she was missing a single gene called UBE3A. And that could be fixed. And I didn't understand how you couldn't just give her back one of the 26,000 plus genes that she was missing, because this gene has a significant impact on her life. And so we went on an odyssey to figure that out. And so I quickly wound up reading every ounce of literature I could. And I really put my clinician hat on. And I went from being a parent to feeling sorry for myself and my family and trying to figure out how I was going to navigate this world of disability that I had no interest in being a part of, quite frankly. And this as we all do as parents, none of us signed up for this. And we have to quickly move in that 30 seconds of diagnosis to being the best advocate you can ever be for your child. And I did that. I tried to do that at least, and to figure out how I was going to manage that with my other daughter and my husband. And then I was about to have, I soon thereafter had a third daughter. And so I quickly put on the hat, took the hat off of tears and put on the hat of advocates. And we read everything we could. We understood everything we could from the literature. And we talked to every scientist we could in the field. And what we both, my husband and I, realized was that we didn't go to veterinary school to be geneticists or neurologists. Quite frankly, I didn't love neurology in veterinary school, but I quickly became one. I became the best epileptologist I could be. But we understood as much as we could, and we talked to everyone. And what I realized very early on, after going to every scientific conference and speaking on the phone with so many willing people that were able to speak to me, and everyone got on the phone with us. I mean, people were just so gracious with their time, was that there was so much work being done in Angelman syndrome. And I was so proud to be part of this community that had so much work being done 10 years prior to our diagnosis. And so I could leverage that work and figure out how I could help. Where can I be a part of this? My therapy to get through this diagnosis was going to be to help. And so I wanted to figure out, how can we take all this great work that was being done in all of these labs and get it out of the lab and bring it toward clinical trials? And as I listened to all these scientists speak, what I realized was that it was a really great decade to be a mouse with Angelman syndrome, but it wasn't really that great to be a human with Angelman syndrome. But my wheelhouse was translational research. And so let me help. How can I help? And so I really leveraged all of that. And I spoke to every scientist and kind of put budgets together and tried to figure out what it was going to take to get out of that black hole, just leap over that hole of translational research and bring this into IND enabling studies and get it ready for clinical trials. And that's what I had to do. And so I wound up asking a lot of questions publicly that some of the scientists maybe were uncomfortable with, because neuroscientists didn't go to school to become clinicians, and clinicians didn't all go to school to be neuroscientists. And so there was this gap. And so I needed to bring that gap together. And so I was able to do that and really figure out what the needs were. And so I quickly was asked to become part of the Foundation for Angelman Syndrome Therapeutics, which was probably the highlight of my life to date, because that changed everything for Quincy and for all the other kids living with Angelman. And so I joined as a scientific director, and then I became their chief science officer. I helped the foundation develop a translational research roadmap to a cure. We came up with a plan for 6 therapeutic platforms, most of which were gene therapies, disease-modifying therapies, or gene editing therapies that had some work, and some of which wasn't yet worked on. And we were going to start a preclinical program, some of which had a preclinical program that we were going to take forward. And we ultimately put a budget together for $5.8 million. I had one of the best lunches of my life with another parent of Angelman syndrome who I had no idea was from Means, but he came to New York from London, and we had a beautiful lunch. I explained to him the new roadmap to a cure that I was so excited about. And to make a long story short, he basically wrote a check for $5.8 million. I had no idea he was from great wealth, but he was, and it was the best lunch I've ever had. And so we took that 5.8 million, we invested that in all of these research platforms. And one of those platforms was an antisense oligonucleotide. And we had a human candidate within 6 months of that investment. And from that human candidate, we decided as a foundation that we were going to take that forward ourselves. And we were going to start a for-profit company out of a not-for-profit. And we started Genetics Biotherapeutics. I became the chief operating officer of genetics and continued to be the chief science officer for FAST. And we brought that forward through IND enabling studies, surrounding ourselves with the best consultants in the world in antisense oligo development and clinical trials. And we brought that through IND enabling studies in about 18 months. And we launched the first phase 1 clinical trial for a disease modifying therapy in Angelman in February of 2020, 18 months from our first in vivo study in our IND enabling. And so we were able to do that through a very small and nimble team, most of which was made up of foundational members or individuals touched by Angelman syndrome, as well as world-renowned consulting experts that were able to help us get through that. And so that trial launched last February, and I have been very involved, not on the clinical trial side, actually not at all involved on the clinical trial side. I have a complete firewall from that, but on the non-clinical side. And so I've been very involved in the drug development process, as well as developing endpoints. And so I became the director of the Angelman Syndrome Biomarker and Outcome Measure Consortium as well. So that we can develop endpoints that are meaningful to families living with Angelman and ensure that whatever endpoints are available and are out there are appropriate for this population, so that we can design clinical trials that are most appropriate for the population and we can truly see meaningful change. And so that's kind of my story, is I wear a hat of a parent, of a clinician, of a community advocate, and of an industry partner, trying to balance all of that in the least conflicted way with the ultimate goal of improving the life of my daughter, Quincy, and the 500,000 other kids in the world living with Angelman, which will hopefully be translated for the millions of other kids in the world living with other neurodevelopmental disorders.
Great, thank you. My first question for you is, do either of you sleep? If not, how in the world did you get everything done? But no, we do have a few questions. What I'm going to do is sort of ask each of you a question, and if the other one wants to jump in with an answer, great. And then I'll try to ask a few that actually apply to both of you more directly. So Dan, there were a few questions that were asked that really get at this issue that you kind of mentioned actually in your summary, with regards to like, how do we reconcile these goals that we have of treatment, and even this concept of autism being a disorder or disease, with the awareness that many individuals with autism have strengths that they may not want change or to lose. I know that's something that you probably get asked a lot, but I think there were a few questions that address that, and I wondered if you could comment on that.
Sure. I mean, I'll start with just some really basic things that have really nothing to do with genetics per se, but just number one, we look at, again, the patients and individuals in front of us, and if they're children, parents make choices for the children all the time, both in terms of treatment and all kinds of medical conditions, what schools they go to, what sports they do, there's things that might impact their safety, whether they can ride a bicycle without a helmet, et cetera. And, so again, we have to trust parents, and again, that's going to be a one-by-one kind of interaction with the physician. When somebody's an adult and has autonomy, they have autonomy, they have choices to make, and it's certainly not our intention to force things on people or to change them. We're talking about ameliorating suffering and optimizing people's outcomes. And so for those with very severe conditions, let's say, like recurrent seizures or intractable seizures, those are things that we really have to attack because they're life-threatening. And so it would be ludicrous and wrong not to do everything we can to stop that. And so again, autism is the autisms. It's a range. We have to treat the individual and think about it that way. And in no way are we suggesting that we want to change who people are, or if they're feeling totally fine and they don't want an intervention. That's of course not. And in fact, we don't have time to really discuss it today, but I've given several public lectures that are actually available, and one through the Paul Allen Foundation that you can find on the web, where I really talk about, we have to move away from considering some of these aspects, some of the forms of autisms and other things as conditions. It's just part of a continuum. There's an aspect of autism that's part of a continuum of human behavior. And we all have strengths and weaknesses, and we all lie on various continuums, and we have to kind of recognize that. And so this really gets into this issue of acceptance, and that I think it's very, very important, not just awareness, but acceptance of individual differences. And I think we're very, very cognizant of that. But we still have about a third of kids with autism who have very severe conditions that include medical comorbidities that we really need to treat. And that's where a lot of us are focusing right now. And as Dr. Barrett mentioned, this is also a place in general in rare diseases where pharmaceutical companies who had gotten out of these fields are now moving in rapidly because they see a potential to have an impact and to meet what have been for decades unmet medical needs. So that's probably enough.
Yeah.
Hopefully.
And actually, I wasn't, Allison, going to direct this question to you as well, but I actually wonder if you wanted to comment quickly on this issue of strength versus areas of challenge, especially, this question comes up in Angelman in particular, because there are certain aspects of Angelman, like the fact that and this is a generalization, and you mentioned in your talk as well, they tend to be really happy, right? And don't have as many of the maybe maladaptive behaviors, especially early on. And I've actually heard parents, concerned about, well, if you have a cure or treatment, will that disposition diminish? Right. And I wondered if you as a parent sort of had, or maybe a CSO, if the company had thoughts on that.
Definitely. It's so personal. And it's one of those, I mean, it's a question parents ask all the time. And I think especially parents of children with significant disability like Angelman, where their biggest strength is their personality. And I mean, you can make the list of weaknesses in the sense of the things that a lot of these individuals really can't do, like speak. Kids with Angelman essentially universally have no speech. And the thing they're best at is their behaviors and their personality, generally 95%, 90%. Have a really great disposition and love noise and activity and animation and fun, and they are a pleasure to be around. They're actually very attractive to be around. They're easy to bring out in public places. They're easy to be up to dinner with. They're easy to manage and handle, even though they have a significant disability. They may not walk, they don't talk, they may have severe debilitating seizures. They may not sleep more than 3 hours a night. I mean, these are all things that are significant disabilities, but they're happy, or presumed to be happy. And so for me as a parent, I look at that and say, I would give up a little bit of happiness for my child to be able to tell me what's bothering her when she has a stomach ache, or when she doesn't feel well, or when she's about to have a seizure, or why she's not sleeping tonight when she slept for the last 3 months. What bothered her tonight? Did she have a nightmare that scared her? I would give up the little bit of happy for like the ability to communicate with my child and understand her needs and wants in the most robust way, or to be able to not see another child in non-epileptic status in the hospital, not knowing how to treat that condition, and they're there for 3 days with an EEG. So that's me. I'm a clinician and I like to fix problems. And so I'm willing to take that give and take of what I might give up if something were to change, because they're over happy. And that may go away a little bit if we see major therapeutic translation and impact. I'm okay with that. Some parents aren't, and that is to be respected and to be expected, really. And that's why every parent needs to make an educated decision with their doctor about, are they willing to take the risk in a clinical trial to see what happens? Or do they want to sit back and wait and see what happens to many other children and see what goes and what comes and what changes are there? And then they can balance the pros and the cons of the changes they might see. But in Angelman, we are almost trained to be proud of their personality because that's their best trait. And to think about losing that in exchange for something that may not be better than that is scary. But for me as a clinician, the things we may gain, and now that we know things maybe have been gained that are tremendous in some of these clinical trials, I am willing to give up a little bit of a happy behavior for my child to speak. And that is just my personal choice that not everybody may feel the same way about. Though, to be honest, the kids didn't lose their happy demeanor when they did gain words. And so I'll take that any day. But we didn't know that, right? When the trial started, no one knew what they were going to see in these children. And it's a real fear that parents have, and we have to respect that.
Thank you. I'm actually going to ask another question that, again, we'll start with Dan, and then Allison, you, I think, again, thinking about your role in drug development and trial design could also answer. There's been a few questions about timing. And, Dan, in your talk, you mentioned how many of the genes associated with autism are most active in prenatal development and at birth. There were some questions around why those genes are more active at that time, which you can answer. But I would also ask sort of a follow-up question, which is, does that have implications for timing of treatments? And do you think that there are some either sensitive or critical periods in which we really need to intervene to exact meaningful change?
It's a great question. We actually I don't want to overstate what we know and don't know at this point. We really don't know for most things how that's going to work. But let me give some framing comments that might help us understand how we think about this. The genes that are acting, the fact that genes, so there are mutations in genes that cause autism seem to be most highly expressed, many of them, not all, but there seems to be a convergence, at least an overrepresentation during early brain development. And this tells us that that's a period of maximum vulnerability. That's really what it's telling us. What happens then after that is what we're trying to understand with research. How do those insults affect later functioning? Does it affect the kind of cells that are born, how they're connected to each other and how the brain is communicating, et cetera? And with all these model systems, we can begin to ask those questions, as well as we can ask them with imaging studies and begin to connect the dots between the humans and these model systems. So it's possible that many of the interventions might not be actually restoring the gene. It might be acting on the circuits that have been disrupted, restoring the circuit function using neuromodulatory kinds of therapies. That's one possibility. Another is that looking forward far into the future, not in the next year or two, we'll be able to diagnose some of these more severe disorders early, and we'll be able to use gene therapies to actually correct it during development. But I think we're very far from that. I think there are a lot of ethical and other issues that have to be dealt with first. I don't think we should jump into that kind of thing willy-nilly. And lastly, I want to say that there are one can engineer these mutations or these risk factors into, let's say, mouse models. And one can watch their behaviors. And there are now more than a half dozen mouse models where the gene is known to act in a very early developmental stage. And yet the mouse model has been treated as a adolescent or adult, and there's been a reversal of a lot of the core symptoms. And so we do have some hope that, again, we will be able to target later once we understand mechanisms. And that's a key part of this.
I could jump in there as well. And I love this question. And Dr. Gershwin, I love your answer for many reasons. And I think I can just use Angelman as an example because that's what I know best. But I think it really highlights your answer to this question, which is we don't know. Mice are not humans and humans are not mice. And so I can give some examples where there is a mouse model of Angelman syndrome, where it's a Cray model. So they can basically give a drug, the gene is missing throughout development, and then they can give a drug, tamoxifen, and they can activate the gene at different time points from birth, which is in a mouse considered like neonatal, like pre-birth in a human, to adolescent or juvenile, adolescent, adult. And they can look at the different symptoms because the Angelman characteristics or symptoms are quite robust and well known in the neurobehavioral space. And so they can look at all the symptoms and see when they're rescued. And so a paper came out that really was considered kind of a hallmark paper in some ways of therapeutic window and what you can rescue at different time points throughout the course of development in a mouse model. And what it found was that you can rescue some symptoms in adults, but you rescue all of the symptoms in the neonate. And in juvenile and adolescent, you rescue less and less as you get older. And so it was very much kind of considered dogma that there is a therapeutic window to rescue symptoms of a neurodevelopmental disorder like Angelman syndrome. Now, there's also data to show that the UBE3A gene is on in their brain, in children with Angelman's brain, until some point in development, whether it's second trimester or third trimester, because there's an imprinting phenomenon where they have it on and then it gets turned off at some point in development. There's argument if that's first trimester or if that's actually within a week after birth. But regardless, we know that in organoids, at least, it's likely in utero. Well, what we can tell you is this has been dogma, that you couldn't rescue many of these things. And now we have a clinical trial in humans that gave speech. I'll cry because it's profound. In 3 months, a 5-year-old had speech within 3 months of a drug being delivered, activating the gene. We were told that would never happen, that there's a therapeutic window that could not happen. Within 3 months, a child developed speech that had absolutely no words. And not only one child, but a couple of children. And not only at 5 years old, but at 12 years old. So what does that tell you for every human that has a neurodevelopmental disorder? It tells you that we don't have the first clue where plasticity starts and ends. We don't have the first clue when there is a therapeutic window and when there's not. And the only way we're going to know is if we try. And if we put it all in so that they have the opportunity to put it out. But if we don't teach our children when they're young all the possibilities of putting in speech, giving prompt therapy, just an example for nonverbal children, giving them language so they can put out language, then we just don't know. And we have to give them every benefit of the doubt. Another paper just came out last week in Angelman syndrome, looking at hematopoietic stem cell delivery of gene therapy in Angelman syndrome. And so this is in a mouse model of Angelman, same thing, very severe phenotype. They gave the gene therapy at birth, full rescue every single phenotype. They gave the gene therapy in an adult, full rescue of every single phenotype. So with a gene therapy, you can rescue every single phenotype robustly in an adult, but with a Cray model, you can't. So what does that tell us? We don't know. But let's hope that the humans give us the sense that we may have a really significant window of life, which we know the brain isn't fully developed until 25 or later. So we just don't know where that continuum starts and ends. And we need to give our kids every benefit and every chance that we may not see full cure in these individuals or full symptom rescue, but we may see a huge change in quality of life and a huge change in skills that can improve their life and their independence, which is the only thing we want as parents for our kids, and likely the only thing our kids want is to live that better life. And so for me, I think the answer is we don't know. Or maybe we do know. There is a chance for rescue after birth.
Right. No, it's a great point. I think it brings up also the challenge around our clinical endpoints and how they're defined based on the age of the child and those sorts of things. So no, great answer. I'm trying to, just so the audience knows, I'm trying to ask questions that both can kind of answer, even though one may have more expertise than others. I think it's actually kind of a unique opportunity to get perspectives from both the science and the parent perspective, even though obviously Allison is also a clinical researcher in her, definitely in her own right. So I'm gonna ask a question that I'll start with Allison around, again, this goal of sort of developing therapeutics and getting all the way to trials and then eventually FDA approval is really the goal here, right? In this journey of precision health. Allison, you've kind of walked that journey, that path at every stage. And in your talk, you talk about, the phases, the patient, clinical, community, industry. Now that you've lived it, what would you say were sort of the biggest pain points, the places where if you had known something different, you would have maybe approached things a little bit differently? And along those lines, like, where do you feel as though specifically, we as clinicians and researchers could be more helpful or have, help facilitate the process a little bit more for the parent advocates who are really trying, to succeed on this path?
That's a great question, and it's really a hard one, because when I look back at everything that we've been through along this journey, I think all of the learnings and all of the pain points allowed us to go to that next step. And I think for me, what I learned most was that by being a little bit naive and not knowing what I didn't know, not only me, but our whole team, allowed us to do some of the most amazing things for our kids. And I think had I known more and had I been a little bit more jaded, I wouldn't have taken we wouldn't have taken the chances we took to just say, well, we could do this. Why? Because we can. Because until you prove to me we can, I believe we can. And so we're just going to go for it. And I'm proud of that. And I think what I learned was that drug development is really hard. It is not easy. You have to pivot. You have to be nimble. You have to be prepared that candidate didn't work. We got to go to this candidate. That doesn't work. We better have a third backup. That doesn't work. I hope you have a fourth. And you have to have monkeys in the background that you're ready to treat and give the drug to understand kind of doing things in parallel and having the versatility to do that, and raising the money and having the support to do that. And we were really lucky we had all of that. So I don't feel that I learned so much in the things that went wrong as much as I learned how lucky I was to be surrounded by so much support and so many experts that were willing to take that leap with us. But I really did learn that drug development is really hard. I don't doubt that. But I also learned living with rare disease is a whole lot harder. And so it's not that hard. Like, yes, it is painful and it is expensive, and you have sleepless nights and you have disappointment and you have a pit in your stomach and you lose 10 pounds because you think your drug candidate isn't going to go forward. Like, yeah, that really stinks. But then I look at this little girl and that stinks more. And so you move on for another day. And I think that's what a lot of industry doesn't have. They don't have who they're waking up to in the morning to answer to. Like, I don't answer to our investors. I answer to a little 6-year-old girl named Quincy. And that's far more powerful. And so I think that's what I always remind myself. And that is the biggest part of our success as an organization, is that that's who we answer to every day. And our investors get the best of that because we make the best decisions for those children. And I think that's my biggest learning, is kind of what we did right more than what we did wrong, which is always putting the child first. I think that's probably the right answer for me.
Thank
Polly,
you. Yeah, Dan,
Yeah.
do you want to jump in? Yeah, good.
Well, I was just going to say a couple things. One is that the pharma industry, and this whole, because of the way it's set up, is going to be relatively risk averse. They have to manage the risk very carefully. It's, they answer to shareholders, right? And although a lot of people do use the answering to shareholders as a shield, a lot of companies do. Pharma companies in general, despite their, some things that are said, are really trying, most of them, to meet unmet needs and to break new ground. But they have to, so part of what we have to do in our space is help de-risk this whole process. And that's what the whole organization that Allison and her colleagues set up did. It really de-risked it by bringing everything on as much of a silver platter as they could. And then, on the other hand, bringing the patients and the families to say, we'll participate in the clinical trial, and setting all of that up, developing endpoints, biomarkers, et cetera. So to the extent that we can de-risk this and kind of, and I think the parent and community organizations play an enormous role in that, as do we in the biomedical research community, in doing that. So I just would add to that. Yeah, and I would also add that, yes, we can. There are a lot of things that aren't done in pharma. I've been working in a different area recently. For example, activating enzymes that are just a no-no. You can't do that. And there are a lot of rationale presented for that. We block enzymes, we don't activate them. Well, we've developed with a colleague at UCLA dozens of drugs that activate a particular enzyme, right? Just there's all kinds of dogma, there are all kinds of things out there. It's not just in pharma, right? It's all across academics, across, the world. Dogma tends to seep in, and we have to, shake that off as we move forward. And that's, again, why this was successful as well, because, it's really blazing new ground and shaking off the dogmas that often weigh us down, all of us.
Yeah, I fully agree with that. And pharma has every great intention. I mean, we have 22 pharmas now involved in the Angelman syndrome space, and every one of them we have personal relationships with, and their intentions are incredible. And they really want to get to know the kids, and they really want to make it personal. But at the end of the day, there's a meeting every quarter to decide if that program is going to go forward or not in some pharma companies, because they're big. And they need to decide, if someone says they're knocking that one off, they're knocking it off. There's not necessarily a big way to change that. And so I do think pharma, their intentions are great. They're particularly in rare diseases, because they are just so personally invested. Like these, they come to the conferences, they involve themselves in the patient advocacy groups. They are just so invested. And if there's a decision to cut it, it has to be cut. And that's devastating for them as well. But when you have these hierarchies, that unfortunately it is just business. And when you have a single drug that you're developing by a company that is only focused on that single mission, you have a lot more versatility, a lot more mobility, and you could be a lot more nimble on how you spend your money and when you're willing to stop. And I think merging those is important, but I think rare disease drug development is very different than big pharma drug development. And we've been very impressed with the drug development teams and all of the pharmaceutical companies in the Angelman space, for sure.
And I would just add that I think it's impressive that there's been, an evolving flexibility on their part with regards to accepting certain clinical endpoints that might not be traditionally acceptable, right? And letting the patient advocacy groups actually drive some of that with regards to really thinking about patient-centered outcomes, which I think is, valuable. So it's been an interesting, journey to watch. And again, you've lived it at every stage. So, so we only have 2 minutes, and we do have a bunch of questions. So here's what there's a few sort of more technical questions about genetics that I'm not going to ask here since we only have 2 minutes, but I'll send them to Dan and he can respond by email. Maybe we can put them on our CART website for those questions. I want to actually ask a question for Dan that, again, there's been many questions that have sort of been around this theme, which is, and you alluded to it a little bit already, but around how does this story in the rare disorders, in these, monogenetic conditions or in the genetic syndromes, how does that relate to or apply to or inform kind of therapeutics in the broader autism spectrum? And I'll just even add to that, thinking about polygenic risk or other pathways to autism that are not clearly genetic or single gene.
Yes. I think, again, that's an extraordinary complex question. And there, it would take a half an hour discussion just to really go through that in detail, give it proper time. But I'm just going to give an analogy, and I'm going to have to give a superficial answer, but and one analogy is cancer. The drug Gleevec that was developed for a very, very rare form of cancer, thought to have a $200 million market. It turns out to be billions a year because it's been used broadly across many, many cancers. The point is that 2 points. One is that as we're targeting genes and specific things in some ways, many of these therapies hit pathways, and these pathways may converge between different rare genetic disorders and common disorders. So they might have therapeutic benefit across. We just don't know that. And I think it's very, very hard to predict. And even when there's a lot known about the mechanism, like in cancer, and a lot known about the genetics, even then it's very hard to predict. So it's one of the reasons why I'm very, very against kind of marketing, and market size driving drug development. What the Engelmann syndrome, what Duchenne's muscular dystrophy, spinal muscular atrophy, these kind of rare conditions really has shown us is that even in complex brain disorders and rare, neuromuscular disorders, if we understand the genetic basis, we can understand the mechanism, we can develop a treatment. That's been proven. This is just the tip of the iceberg. So we need to move forward in those individual rare disorders as fast as we can, because we need to impact those families and patients, and because we can. And how that relates to the broader kind of community and the kids with with different forms of autism remains to be seen. But the beachhead is in those kind of rare forms in terms of drug development. That doesn't mean there's not a lot of other things going on in autism, that are regarding, cognitive and behavioral therapy, which we have now, in which there are many different therapies, including those developed at UCLA, like Jasper, and that are extraordinarily effective in those kids who respond to it. So, so again, I think there's hope on a lot of fronts. I want to end with that. I think it's uncharted territory, and but we can see that there, some evidence of real progress and hope.
Great, thank you. So I'm going to wrap up with a quote. I'm going to quote Allison, who said in her talk that, and it's her slogan, her motto is that everything is either possible or impossible, and there's nothing in between. And I think that those are words to live by. I think that belief has actually driven not only patient advocacy, but also innovation in science over the years. And I think these two speakers today completely embody that belief, right? That anything's possible. And I think that hope is profound. And so I thank both of you for joining, and for all the audience members for your fantastic questions. Thank you.
Thank you for the opportunity. It's been great.
Thank you, really. Okay, so now, first of all, I want to thank both my Dr. Jesty and Dr. Barrett, as well as me, really, that was really great. Thank you, Shefali, for emceeing that. The next speaker and the next session really is focused on health disparities and equity. And our speaker, again, is another distinguished child psychiatrist from outside of UCLA, but somebody who we have been collaborating with for more than a decade and who is an extraordinary leader in the field, Dr. John Constantino. And I bet because he lives in St. Louis, he would even come here in person to do this, but we'll just leave it at that. And then our own Dr. Connie Kassery, who herself is a pioneer in development of treatments for infants and kids with autism and working in the community here in Los Angeles, will moderate. And I want to thank both of you for taking your time for this. And I'm really looking forward to what I think is going to be a very spirited discussion. Thank you.
Pleasure. Thank you, Dan.
Great. So I have the pleasure of getting to introduce you, John. So I'm Connie Kassery. I'm a faculty member in CART. And so John Constantino, as Dan was saying, is actually the Blanche F. Idelson Professor of Psychiatry and Pediatrics at Washington University in St. Louis. And you direct the William Greenleaf Elliott Division of Child Psychiatry. Everything has a name. Directs an NICHD Intellectual and Developmental Disabilities Research Center and serves as psychiatrist in chief of St. Louis's Children's Hospital. He completed a triple board residency, pediatrics, psychiatry, and child psychiatry at Bronx Municipal Hospital in New York and the Albert Einstein College of Medicine. And his work is focused on understanding genetic and environmental influences on disorders of social development in childhood and their implications for preventative interventions. You pioneered quantitative methods for elucidating commonly believed behavioral and neurodevelopmental endophenotypes that predict autism recurrence in families, and methods that you've developed have actually been used worldwide. And so we had a very interesting presentation by you. I'm going to ask you to just summarize that for those who maybe watched it a few days ago or haven't watched it, but I'm sure everyone has. The title was Genetic Epidemiology and Pathways to Equity in Autism.
Sure. Well, thanks so much, Connie. I'll just say, just for the audience, it's a great pleasure to be here and to have been invited to this wonderful day, a symposium. Connie mentioned the names of these things. Let me just say, William Greenleaf Elliott was the founder of Washington U. And when I became the director of the division, which is named after William Greenleaf Elliott, who is was the grandfather of T.S. Eliot, the chair of the Department of Psychiatry said, not so sure we need that name on child psychiatry anymore because they sure don't give us any money. And we said, no, we would rather keep the name of the grandfather of T.S. Eliot. And one of the great things about T.S. Eliot, and the reason I'm saying this, William Greenleaf Elliott, who was his grandpa, was in addition to founding Washington U, he was consummately devoted to equity for the poor. And he actually pioneered settlement houses for all the people that were migrating west and crossing the Mississippi River. So we're very proud to have his name still. He doesn't give us any money, but it's a great heritage. And our topic for today is disparities. And so I'll just take a few minutes to review what I identified in the talk as kind of my top list of disparities in autism. And at the very, very top, leading the list is the disparity that we have characterized that affects children who are African American, and this broadly widens to other minority groups. But the very serious concern that these children, it is unequivocal, have worse outcomes as a function of race. And the nature of the worse outcomes is not a kind of a mildly more difficult course, or what we often think of in medical disparities of of the poor or minority children that might have excess cases of asthma in a year because of disparities in their health treatment. This is a health disparity that has to do with the fact that Black children with autism in the United States have close to a 50% rate of intellectual disability. That's a fact. And that compares with the national average of about 25%. And in an article that I described in the talk and that we clarified in a journal article last year, a study in pediatrics involving over 500 individuals with autism who are African American, that discrepancy in IQ outcomes is not explainable on all of the usual things that we give ourselves excuses about, like only the more complicated or only the more severe kids are identified, or like it's about low income, or like it's about other family genetic background and cognitive outcome. It has nothing to do with that. And so it is incumbent on us to identify what is the cause of that disparity. And that disparity has been labeled by other scientists in the field now as a sort of a scientific demonstration of structural racism in autism. And so we can maybe talk about that. And then I hit on a few other areas of disparity in autism. The last talk, there was Shefali and Dan were just talking about this issue of monogenic autism syndromes. And I'll say, as somebody who studies polygenic autism syndromes and inheritance in autism, that I think there's a little bit of aristocracy in science around monogenic syndromes. And of course, it is very important that they are biologically tractable pathways to understanding the biology of autism. But the fact is that these monogenic syndromes that are mostly caused by de novo mutations violate many of the rules of autism because they are not inherited and because most of the time they are associated with intellectual disability, and they never are associated with sex disparities, which is part of the entire human population of autism, for which inheritance accounts for over 85% of the cases. And so we have tried to put forward a reason to concentrate on the inherited cases. And that has to do with the fact that even though we don't have a parsimonious biological pathway of a gene, we've started to discover parsimonious biological pathways of developmental endophenotypes that could be targeted in treatment and that represent true targets for all people that have inherited versions of autism. And then I talked about the disparity inherent in sex in a kind of a unique way, which is that until a couple of years ago, we really didn't even know that if you were a brother or a sister of somebody with autism, what would happen if you started having children, and what would be your risk? And it has to do with understanding and elucidating the nature of the female protective effect hypothesis in autism for the sex ratio, and the discovery that in fact there is not as much risk that accumulates in unaffected females as the female protective effect would have predicted, and therefore it is somewhat safer for the sisters of individuals with autism to consider, the situations for their offspring than would have been predicted by that hypothesis. And so I talked about that. And then finally, the last two have to do with the disparities that affect either people with very rare autistic conditions or individuals with autism who are affected by COVID-19, and that those represent also very significant kind of disparity situations, that if you're orphaned on the basis of the rarity of your condition, or if you are an individual with autism experiencing this pandemic and you have a remarkably disproportionate share of the burden, whether you're infected by COVID or not. And so I'll leave it at that as a summary, and Connie, I'll turn it back to you.
Great, that was great. Well, I thought your talk was great. I have lots of questions about the racial ethnic disparities, but actually I'm going to start with some of the genetic questions because our audience had already submitted several questions. So with the first one, it's talking about the Swedish lineage study in mind, a desire to better understand the risk and a desire to provide needed guidance. Would there be any increased statistical risk of autism beyond that noted in the study? in the male offspring of an unaffected fraternal twin sister of a seriously affected brother whose two older brothers also have ASD of varying severity. Don't you love that? Did you follow
No.
all that?
I want the audience to think that in a snap of a finger, I could unpack that whole thing and have just
Right.
the right answer. But luckily, Monica sent me that question, and it's
That's
a really
right.
great question. But to unpack it, what the real question is that the question is about a twin unaffected sister, a fraternal twin, which is like, you know, a same genetic relationship as any sibling. And so it's the situation of a female unaffected sib of an individual with autism where it's known that autism is running in the family. And that's very important. It's a great question because if it's a sporadic case of autism in the family, well, you know, that brother that's affected could have been rendered having autism on the basis of a de novo mutation, which would give the sister very little risk or no risk of transmitting that same liability to her offspring. But if that individual that she's related to, that brother, has a form of autism that's inherited, which is the most common kind, okay? And even in sporadic cases, we have to assume that the sporadic cases are really inherited unless it's proven that they are from de novo causes. Then when in this case, we knew that in this situation, we know that this is an inherited familial autistic syndrome because it's a multiplex family. And so that would boost the rates up a little higher. So what we reported in that paper is that the risk to that sister is about 2 to 5% that her offspring would have autism across the board of not knowing anything else about her brother's autism. But knowing that it's multiplex autism, that boosts it into the 7% range for her offspring. And remember, a 7% risk would translate in a 3-to-1 fashion in the sex of her offspring. So that would be more like a 15% risk for her boys and a 5% risk for her girls. And so that, I think, is for some families, that kind of information would be actionable about, you know, kind of counseling about preconceptional risk.
Okay. So there's another question, which is basically asking about having a second child. If the affected first child has a de novo mutation, do people often assume that there's population background risk for the second kid?
This is another fantastic question. And the answer to that lies in the principle that not all de novo mutations are created equal. So there are certain de novo mutations that have a 1-to-1 correspondence with developmental disability conditions. Let's take Rett syndrome, for example, okay? And so in the condition of a member of the family having Rett syndrome, on the basis of that de novo mutation, it's very unlikely that there would be any other risk that is occurring or that could be inferred above the population average, because that de novo mutation is so deleterious that usually is the principal cause of the condition. But most de novo mutations are not that powerful. Most of them are either pleiotropic or only partially explain the cause of the condition. And if it's that kind of mutation, so let's take some of the common chromosomal rearrangements, which can be de novo, 16p11.2, 22q11.2 deletions. Those kinds of variants definitely boost risk for autism, developmental disorders, cognitive impairment, and so forth, but they interact with the genetic background, and they don't, in any case that has that as a finding, they are not necessarily contributing all of the risk. And so therefore, it could be inferred that there must be something else that's contributing that risk, and therefore other families have that risk. And this is exactly, I think the person who asked the question had pointed out, that there have been studies, including those that were involved the AGREE gene bank, that showed that in a multiplex family, you can have two individuals with autism in the same family where one's got a different de novo mutation than the other. Like, now how does that, what does that mean? Like, how do we even think about that? And the way we think about that is that those de novo mutations are probably not the only cause, and there is part of the liability to the condition that's running through the family, and that if child 1 gets this de novo to put them over the edge, and now child 2 gets that de novo to put them over the edge. Putting over the edge is partly about a background in that family that's still an increased risk, and that can definitely happen. So then the question is, well, how do we quantify the effect of a de novo mutation on a disease? And we are just getting to that now. And that was part of my presentation, actually. One of the things that we are doing is to try to take all of the clinical genomic information that gets generated by genotyping in the clinical realm all over the world, and to try to amass enough instances of each different kind of genetic variant so that we can say what proportion of the time in an epidemiologic sense does this end up with the condition of interest versus other things versus you have to have something else. And quantifying that impact is very important, because remember, most of the de novo, the rare de novo mutations that have been associated with autism, especially the single gene mutations, are ultra rare. And the only reason that we can detect them is because they have such a one-to-one correspondence with the condition. These ones that are milder, it's open season. It's the Wild West of knowing what is the relative contribution to the condition. Even if they are associated, we don't know how much.
Yeah. Okay, I think there's a lot of interest in this issue that you've raised about racial disparities and access to services. And so there's a general pediatric provider that works for an underserved community in a resource desert. And they're looking for information to help guide patients who are waiting like at least a year to see the one developmental pediatrician in the state. And they're asking, you know, like what resources you recommend that are trustworthy and to help parents sort of along this journey. And I think, John, you and I might actually have some different opinions on this, but I'd be curious as to what your comments are.
Sure. Well, I'm a public health person first, and then a specialist purist second. And that it goes back to sort of training at Bronx Municipal Hospital and thinking about the same kind of situation at hand as this practitioner. And I'll just put it out there. I think you should do it yourself. I think the two tools are available that most children affected by autism can capably and competently be assessed with the help of a sort of a cadre of confirmation tools that we have. And when those tools are used responsibly in primary care settings, there is no reason, in my view, that 2/3 of all children with autism can receive an appropriate, competent, correct diagnosis by their primary care physician. And think about it. If the wait list for the developmental pediatrician is a year long, and you can cut that by 2/3, it's not going to be that long of a wait list anymore. It's going to have an exponential effect on that wait list. And so I am really, and I've spent part of my career trying to empower primary care physicians and primary public health settings with tools that are feasible for implementation. And they are not necessarily the absolute gold standard, but are they appropriate and good enough in the hands of a primary care physician for many cases to reach 100% certainty that this is the right diagnosis. And then for the ones where, well, there's too much conflicting information or it's not clear enough, then save those for the specialist and not flood every case having to go to a specialist. I think we're hurting ourselves from a public health standpoint. And I certainly, will make the stand that what we know about not only the diagnosis and the timing of diagnosis, which in this country, for African-American children is 3 years after their parents identify a concern. And for white children, it's 2.5 years after their parents identify an initial concern or something like that. That's inexcusable as far as I'm concerned. And to stick with, specialists to make that call and get those children moving through systems that can provide them access to services is a significant problem.
Yeah, I think that's a great answer. I agree with that completely.
Oh, good. I'm so glad you agree.
I think where the issues come in, and we've got a few more questions about this issue of disparity, I think where the concern comes in is where we haven't involved the schools enough, because children at age 3 are eligible. And even before that, honestly, if they have some kind of developmental delay, they're eligible for services. And we're not doing enough, I think, to either connect the research centers and the community practices. We're not connecting enough to those services to help and to really improve those services for everyone.
Well, and it's a travesty, because the problem is that there's a structure built into the system right now that Part C, okay, which is birth to 3, is completely divorced from the educational system.
Correct.
And for some things, maybe that makes sense, but for this condition, that makes no sense. That is a complete fragmentation. And there is no reason that there should be those kind of disconnects and hurdles. Some children under Part C will get their diagnosis and initiate their early intervention services and then fall off the map because they have to start all over again with the schools. And we can do better than that. I think the states have to do better than that. And we have to, I think as a scientific community, we have to guide the states that this is not 1920 anymore, and that we need to do a better seamless job with a certain group of these children, that we have to move from one system to another in a much more seamless way.
Right. So I've written some policy, blurbs on this, but I think the issue is the difference in systems, that we need one integrated system.
Right, of
So
course.
for birth to 3, it's developmental, it's DDS, and for after 3, it's 3. And you're right, the diagnoses are different. And in fact, California is on federal watch because we under identify kids across all ethnic, racial areas.
Well, and can you imagine why on earth would we impose a bureaucratic structural fragmentation of the continuity of care right at the time when, like in the year after a diagnosis is made, and that the services should be starting and that they have their highest impact? I mean, it makes no sense.
That's right.
Yeah.
So there's some more. So someone's asking about the advent of telehealth assessments during COVID-19 and how that might be a way to close the gap on some of these disparities, even when a provider isn't in the family's immediate area.
Spectacular. Absolutely. I mean, I think, and it's working. Connie, your team has done this even with parent implemented interventions.
Right.
We have been doing this with even observational methods, and I think UCLA has done this as well. There are ways that these can be implemented virtually, and they work, and they're not perfect. And there are some kids that just can't do it, and families, and there are going to be exceptions where virtual is just too difficult to do. But again, can we skim 2/3 of the pool and get it done virtually? You bet we can. And the next thing is going to be, well, should there be centers of excellence that provide this virtual care more centrally, especially in federally mandated programs, so that it doesn't have to be every single state that's doing it, like that's for at least for the diagnostic process. We could think about efficiencies, if we can, be allowed to operate across state lines. There's all kinds of ways, but there are virtual methods for all of the elements that we do. Surprisingly, for clinician confirmation of diagnosis, for parental registering and teacher registering of traits and features toward a diagnosis, for the intervention itself, to train parents to implement that intervention. So I think it's a very, we've learned a lot from COVID, as horrifying as it's been.
Yeah.
We've learned a lot from it.
Yeah, there's one question here about that I think we should tackle just in our last couple of minutes. And that's, do you think that poor parenting techniques and lack of stimulation at early stage lead to poor outcomes? In other words, attributing it more to that than to genes. And I think we need to stop.
You bet.
Go ahead.
Look, first of all, when you look in human populations broadly about the causes of autism, and you try to find an effect of parental rearing in the cause of autism, there's no trace of it. And that's not to say that parents aren't important, but parents do not cause autism. And frankly, I think it's people like Connie who have demonstrated that the pathway to rehabilitating and or preventing autism in early development is not about being a super parent. it's not about being intuitive. Like it's not intuitive that just what a great parent would do would get a kid out of that liability, because that doesn't work. It doesn't work population wide. There's really great parents in the population and really, kind of marginal parents in the population. And that doesn't have an effect on autism. But what does have an effect on autism, and at least as far as adaptive functioning, is when you take very focused, non-intuitive, razor sharp approaches to specific competencies that a parent would never know, how to do this, exactly how to do it, have to be trained. It's not natural parenting, but is very specific focused intervention. And I look for new opportunities to find, laser focused kinds of non-intuitive efforts to modify what a child experiences, how they're motivated to orient to the social world and so forth. And to diminish some of the developmental liabilities that may not be so obvious to parents. Problems with cerebellar mediated learning, various kinds of things that I think we may have a play at, but it's not about being a good versus a bad parent. And I think that appropriately got thrown out a long time ago. There's no evidence for that.
Absolutely. Well, we're coming to the end of our time, so I'll just, add that I think the work and disparities in our communities is really important, and that maybe the way that we need to think about treatments in the future is more about tailoring them, with cultural adaptations, and that we don't have all the answers yet. And that I think finding those novel and new ways to engage families and to make interventions more effective, maybe a direction that we need to go in.
Well, and I agree, but I also would say too, in very plain English, that minority children deserve to have access to the interventions that actually work. And we have a very strong suspicion that having almost no access to those interventions, which is the average in the period in which they could be most successful, is playing a role in lifelong patterns of more adverse cognitive outcome than their white counterparts. And so I think we have to avail all children to an even playing field of what actually is available, because some of it, thanks to people like Connie, is actually good and it's working, but it's got to be an equal playing field. Otherwise, we're going to perpetuate these disparities.
Right. We're trying to equalize it by working with the schools where all kids go to, all kids have access. So.
You bet.
Okay. Thank you so much. It's great.
Great. Thanks for the opportunity. Pleasure.
Thank you very much, both John, for taking time out of your day in St. Louis at WashU, and Connie for moderating as well. Thank you so much. Now, again, we're at a point for our next 10-minute break. So come back at, I guess it'll be 11:50 for our next set of talks and interactions. At 11:50, we're going to be talking about adult intervention. See you soon. We'll be starting back in 1 minute. Just a 1 minute warning. Well, welcome back, everybody, from the last break. It's great to introduce the next session, whose topic is adult intervention. And this panel will be moderated by Dr. Mike Gandel, who's an assistant professor of psychiatry and a relatively new member of our Autism Center over the last few years. And it will feature two speakers who, especially many of you locally here, will know well, Dr. Amanda Gulsrud and Dr. Elizabeth Laugesen, who will discuss their work in intervention and treatment for adults with autism. Thanks to all of you for spending your time with us today.
Thank you, Dan. And I have the distinct pleasure of, my name is Michael Gandel. I'm an assistant professor in psychiatry in the at UCLA, member of the CART team, and I have the distinct pleasure of introducing today my two esteemed colleagues, Dr. Amanda Gulsrud and Dr. Liz Laugesen. Dr. Gulsrud is an associate professor in the Division of Child and Adolescent Psychiatry at UCLA and a licensed clinical psychologist who specializes in autism and, excuse me, and the development of behavioral interventions across the lifespan. She is also the clinical director of the multidisciplinary CAN clinic here at UCLA, which focuses on the evaluation and treatment of individuals with ASD also across the lifespan. Dr. Gulsrud's research focuses on the early identification and treatment of infants and toddlers with ASD and related neurodevelopmental disorders using the JASPER intervention, which is a naturalistic developmental behavioral approach developed here at UCLA. And as part of our UCLA Center for Excellence in Autism, Dr. Gulsrud is a co-investigator studying early risk markers and interventions for 12 to 36-month-old infants and toddlers with ASD. She also co-leads the Autism Intervention Research Behavioral Health Network, which aims to address a gap in identification and service for low resource families of those affected with ASD. And she leads UCLA's participation in the Simons Foundation SPARK study, which is a really important initiative to build the largest genetic research cohort in the US for autism. And most importantly, regarding our topic today, Dr. Gulsrud and her colleagues have launched the UCLA College to Career program, post-secondary support service program for young adults with ASD. And in addition to Dr. Gulsrud, we also have Dr. Laugesen, who also has a very lengthy set of accomplishments. Dr. Laugesen is, and I might also mention, is very kindly taking time from Hawaii to talk with us today. It looks very beautiful out there. Dr. Laugesen is an associate clinical professor in the Department of Psychiatry and Biobehavioral Sciences here at UCLA. She's also a licensed clinical psychologist. She's the founder and director of the UCLA Peers Clinic, which is an outpatient program providing parent-assisted social skills training for individuals with ASD and other social impairments, ranging from across the lifespan from preschool to adulthood. Dr. Laugesen is also the training director for the UCLA Tarjan Center for Excellence in Developmental Disabilities here at UCLA and Program Director for Dissemination, Outreach, and Education within the UCLA Autism Center for Excellence. Dr. Lageson's trained thousands of mental health professionals, educators, families in the PEERS method, and is really dedicated to developing and testing new evidence-based treatments to improve social skills across the lifespan, which we'll discuss today. Her program is now being used in over 70 countries and has been translated into over a dozen languages. And so we're really honored to have both of you here today for our session on interventions in adults with autism. And I was thinking we could just start by having both of you kind of summarize the TED Talk version of your video talk for those that weren't able to or that don't remember the contents.
Sure. Thanks, Mike, for those introductions. And I want to know who gave you those bios. Way too long. They're going to take half our discussion time. Hello, everyone. Thanks for joining. I'm Amanda, and I'm going to give a brief summary. So the way that we presented, we actually co-presented on this topic of adults. And we thought about kind of 5 key areas of focus. And so in the first part of the talk, I really dived into what we know, what the evidence is for post-secondary education outcomes and treatment services for this transition period. I also looked at independent living skills. We know that as individuals with autism age, they actually see a decrease in their adaptive functioning over time. That's really a unique growth curve in autism. We know that means more support is needed in this area. And so we looked a little bit at what we know from the evidence about treatments and supports to boost independent living skills. We also looked at mental health outcomes. Adults with autism have a really high comorbidity of a host of mental health concerns, including anxiety and depression. And it's a real concern in adulthood that we don't have specific treatments that are really adapted to meet the really complex needs of adults as they age. And then Dr. Lageson also talked a little bit about social emotional development and employment. So I'm going to pass it over to her in 1 minute to give a summary. But I do want to highlight a few things from the beginning of my talk that I think might be relevant today. So really this idea that, you know, even though we've come so far, we don't have enough support and services. And unfortunately, some of our newer research has shown there's such a paucity of these types of services available that it's really a growing concern, given that more and more people are aging into adulthood. So we need to do better as a research community and as an intervention community at really building out a system. It's a system-wide problem. And I think I was able to highlight a few rigorous research designs. So these are our randomized controlled trials that are looking at outcomes for adults that we think are very important. And a couple of themes to highlight. One is that of self-determination. I talked a little bit about that. A really important area. I think these types of interventions can start earlier. They're interventions that really help empower that individual to make their own choices in life, to set goals and to attain those goals. And that is a really important piece because we see a lot of adults on the spectrum who arrive at adulthood and aren't quite sure what they want to do with their life. They don't know what employment opportunities are available. They may have, look like they have pretty low motivation. And I think we need to treat and target that area earlier. I also highlighted the role of the aging caretaker. And I think that that is an incredibly important piece as well. As our adults age, so do their loved ones that have been taking care of them and providing support. And we need to do better by our parents and our caretakers in providing support specific to that. And so those are just a couple of things that I talked about. But now I'm going to pass it on to Dr. Lageson to tell you a little bit more about social, emotional, and employment development.
Thank you, Dr. Goldsrud. Aloha from the beautiful island of Kauai. Thank you so much to Dr. Gandel for moderating this session. So as Dr. Goldsrud mentioned, I also in our talk discussed a little bit about some of the social emotional development issues and interventions for adults with autism, as well as employment. And with regard to social emotional development, the areas that we targeted in our talk were around romantic relationships, sexual relationships, and friendships. We know social skills training, for example, is a very common method of treatment, particularly for younger children and adolescents. But as we highlighted in our talk, there is really a dearth of evidence-based treatments for adults in these areas, focusing on social emotional development. We did highlight a couple of programs though that are showing some promise. With regard to romantic and sexual development, we know that this is an area that a lot of adults struggle with, in terms of developing and maintaining healthy romantic relationships. Many adults will say that they want these types of relationships, but don't necessarily know how to go about developing them. So we highlighted a couple programs again that looked promising. One of them is called the Relationship Enhancement Program. It was developed by Allie Cunningham and her group at Florida Atlantic University. It was based on a program called Ready for Love, and they were showing some promise with this program in a small pilot study. We also highlighted the Tackling Teenage Training Program out of the Netherlands. This is a psychosexual education program with a pretty big sample. They were focusing not just on teenagers, but also young adults, and again, had some promising findings in this area. And then with regard to friendships, we highlighted the UCLA Peers for Young Adults program, which has probably the widest evidence base in terms of being researched not only at UCLA, but in multiple studies outside of UCLA, and so highlighted some of the findings from that program. With regard to employment, we also gave an outcome, a sort of overview of some of the outcomes for adults in the spectrum, which again, I think most of us know don't look too promising. Unfortunately, there's definitely a higher rate of unemployment and also underemployment in adults with autism. And unfortunately, there's just really a lack of services to prepare adults with autism for employment, and also a dearth of evidence-based treatments to support employment. Some of the areas that do show some promise in terms of employment would be supported employment programs that include things like job coaching. And one of the programs that is probably most well researched would be Project Search. And we highlighted some of their outcomes for adults with autism. They have pretty large samples, which is nice, and really promising results in terms of obtaining competitive integrated employment for adults in the spectrum. And then we were also very excited to share some pilot findings from Peers for Careers, which is a college to career transition program that we developed at UCLA, and Dr. Goldsrud and I conducted a pilot study a couple of years ago. We were able to share some of those findings, and also very excited to announce a larger randomized controlled trial that we're currently doing through an Autism Speaks Adult Transition Research Grant. And so happy to share more about that if people are interested. But I think in terms of the key points that we wanted to make in this talk, as Dr. Goldsrud mentioned, there's upwards to about 100,000 adults, or individuals with autism entering adulthood every year. And unfortunately, only about 2% of our research is really focused on adulthood. And so there's really this lack of not only services, but evidence-based treatments for this growing population. And while there are some promising studies and promising treatments currently under development, there needs to be more. So that's sort of the takeaway. And I guess at this point, we'd be very happy to open it up to questions. And again, Mike, thanks so much for helping to moderate.
Yeah, thank you both for summarizing your talks and work. And so I think while to open this up, I think it's really an important area, and I think you guys did a really nice job highlighting the sort of lack of the very important need for more research into services for adults with ASD as this group becomes larger, and part of the challenge, I think, is that there just hasn't been that much work, but also that there are a lot of unique challenges that that individuals on the spectrum will begin to encounter during adulthood that maybe aren't as prevalent during sort of childhood and adolescence. And so one of those unique challenges becomes this idea of romantic relationships and dating in particular. And Liz, I was hoping that you could maybe comment a little bit about how you see helping support individuals, adolescents and adults on the spectrum for dating and the Peers for Dating program.
Oh, thank you for asking that, Mike. I appreciate that. Yeah, we actually are conducting a randomized control trial right now on a program called Peers for Dating. And it's a program that's relatively new. We've been teaching dating etiquette in our young adult programs for many years, for over a decade, but we've never had a program particularly just focused on dating etiquette until now. And I'm very excited about that. What's unique about this program is not that only that we're just teaching dating skills, things like, conversational skills, letting someone know that you like them, asking people on dates, going on dates, psychosexual sort of health and safety. But we have this dating coach component. So what we've done is we've randomized young adults to either receive a dating coach, which would be an undergraduate or graduate student interested in supporting adults on the spectrum, or they're randomized to not receive a dating coach. Very similar to the model that Amanda and I are using in the Peers for Careers program. And so that's the element of the program that we're really testing to see what's the benefit of including dating coaches. But this is an area that's highly understudied, as we highlighted in our talk. And we're just taking a pre-existing program, Peers for Young Adults, and really refocusing the intervention on ecologically valid skills to develop and maintain romantic relationships. With the hypothesis that we believe that the dating coaching is going to be really key to success. I mean, very few people, even typically developing people, date alone, right? Most people get support from their friends or their family. And so we're trying to look at that a little bit more closely, and very excited about our current cohorts, and they seem to be anecdotally going quite well. So happy to share more if people are interested, but I appreciate the question.
I can imagine these are very popular groups because so many of our young adults and adults are really seeking romantic and lasting relationships. And I think there's a misnomer that for whatever reason, adults with autism don't want that connection. And that's not true at all, right? And so I think that it's important to recognize that, you're an adult first, and you have autism, and and that doesn't mean that you don't want to have a lot of these important outcomes that really, load onto well-being and happiness. And part of it is being successful in that realm. So thank you, Liz, for thinking that far ahead and diving into that topic, because it can be a hard one to navigate.
So another challenge that's sort of unique to this age group is the transition to employment and thinking about joining. And so, Amanda, I was wondering if you could speak specifically on programs designed to help facilitate that transition. And there's along the lines, one of our attendees has asked, what can employers do to help support a person with autism in the workplace?
Yeah, excellent question. So we asked the same question a couple of years ago when we had many families coming to us saying, I have a highly educated, smart, bright, 20-something-year-old, son or daughter on the spectrum. And for the life of him or her, they can't find employment that is meaningful and successful. And we started to really think about that. And we did develop a program and do some piloting in this area. And I think important to think about is, it doesn't end with just finding a job. So we found that our young adults really need to be prepared on the front end, right? They need to have access to things like, how do I create a resume? How do I go into an interview and be successful? Do I disclose my diagnosis or not to an employer? All of these things, they're actually not things we're taught explicitly growing up, if you think about it, but we need to actually be more explicit with our population and really fill in those gaps so they can be most successful. But the thing that I found was really striking, and what we're kind of in the thicket of right now, is how do you maintain successful employment? And I think that that really has to do with careful relationships with employers. And so that question we just had about, what can an employer do? We're lucky to actually interact with a few programs now where they're focused on preparing employers to have these relationships with individuals on the spectrum. Some of it is around just education and raising awareness, but a lot of it is around finding like a champion or a coach at the work site that can really work more closely and check in with that individual. And I think that kind of peer model program or coaching program, I think is a really critical active ingredient in this that will really maintain and sustain meaningful employment.
Thank you, Amanda. So we've had a couple questions from the audience about the sort of getting access to these programs. I know that a lot of them are sort of more in research phase, but Liz, I was wondering if you could talk a little bit about any tele type of approaches that you are all taking and about, excuse me, access for individuals from other countries and things like that.
Thanks for the question. I mean, that's a really important question. A lot of people are asking, or how do you even access these services? And I think one of the themes that we've been hearing in some of the other talks today too relate to telehealth services and how that's really broken down a lot of barriers, oddly, over the last year. So Amanda and I were able to move, for example, Peers for Careers into telehealth, delivered over Zoom relatively early last year in the pandemic. And so all of our, college to career transition programs right now are led over Zoom. And so they are available to people outside of, Los Angeles. In terms of Peers for Dating, that's actually open to people across the US. It's also delivered over Zoom. And that's done weekly for about, 2.5 hours a week. It's pretty accessible as long as people have access to, the appropriate electronics and Wi-Fi, which I know can be a barrier for some. And then all of our other telehealth services for both adolescents and young adults, for Peers for Young Adults and Peers for Adolescents, are also offered over telehealth. And so we have temporary licenses in different states across the US to provide telehealth services, as well as we have educational groups that are open worldwide. So really that's our catchment area, it's the world there, which is really nice. So we have people zooming in from, China and all over the place. It's, there's the time change. That's not always fun. But the good news about these telehealth delivery methods is that we've also been collecting data on all of these programs throughout over the last year. And what we've discovered is that our telehealth outcomes, at least in Peers for Adolescents and Peers for Young Adults, are equivalent to our in-person groups, which I was very pleasantly surprised by. I mean, anecdotally, leading those groups, we see that, right? Clinically, you notice that, wow, this is really working. But it's really nice to have data to back that up. And so there are no statistically significant differences between the outcomes in in-person groups and telehealth groups thus far for our adolescents or young adults. And in fact, in one area in particular, they do better in telehealth, and that is in social engagement, which again is so surprising. Social engagement, having get-togethers with friends. Well, they're having get-togethers online with friends, but that's actually even more enhanced right now in terms of just socializing with friends than even our in-person groups. And so I think that it's very promising. I don't see telehealth going away, even after hopefully this pandemic is in the rearview mirror. And I think it actually opens up access to these services on a whole different level and it seems to be working. So I think it's here to stay.
And I think I would just add, because I think, you know, a bit of the elephant in the room is that it does work for certain types of individuals. And we do have to remember that we do have a whole adult population who is not able to access, for various reasons, telehealth therapies very well. So they may be more cognitively impaired, more language impaired, more severe in their autism symptoms. And I would just say in general, I think that's an area that we really need to focus on with adults. I couldn't find much of anything that's going on to really support, you know, outside of, you know, conservatorship and guardianship and residential and those types of treatment settings. Like we're really lacking in what do we do to try to kind of boost outcomes for that population. It feels like most of what we focused on is for more verbal, more able individuals. And so I just want to point that out because I know we have a broad audience here, and I think that's an important piece as well.
Yeah, I appreciate the additional comment there. You're right, Dr. Goldsworth, because you know the programs that I'm talking about right now are focusing on individuals that are adolescents or adults. They're verbal, they're of average or above average intellectual abilities, and that's a very different population than some. For example, our Peers for Preschoolers program, that actually has been on hiatus for the last year because try to teach social skills over Zoom to 4 to 6 year old kids, whether they have autism or not, this is challenging. So there are certain programs that just aren't going to make the transition to telehealth, and we have to recognize that as well. So thank you for the point. It's a good one.
And along the lines of telehealth, there's a couple of questions specifically about dating apps and how whether they can be used to help facilitate some of these the social skills programs. I was wondering if you guys could comment on that as well.
I'm happy to comment on that if Amanda wants to add as well. That's great. There are a few online dating apps specifically for that community. Hiki, H-I-K-I is pretty popular. There's Autism Date. And, in both of these apps, there's also the option of not just dating, but, developing friendships. And I'm not advocating them by any means. I'm just sort of mentioning that they're out there. I think that there needs to be more research on the utility of these programs, the safety of these programs. I think there are always going to be sort of safety concerns. And so when we teach dating etiquette in our programs, we talk about online dating quite a bit because we know it's a very common method for young people in general to meet potential partners. But there's a safe way to do that. Not meeting, in someone's home. You meet in public. You get yourself to and from the date. You tell your friends and family where you're going. You check in with your family and friends before and after. So there's ways to be safe, even with these dating apps. But I think the jury's still out on how effective they are. They are becoming more and more popular, but they're not just for dating often. I mean, there even are gaming options within some of these apps, and definitely friendships can sometimes be a target as well. So I think we need to investigate them a little bit further. They're pretty new at this point, but I would just say be careful and be cautious, just like you would with any type of online dating app.
And Liz, just to follow up on some of the dating questions, are there any programs that are kind of more geared towards girls who are on the spectrum?
Yeah, there's a program out of University of Kansas developed by Renee Jameson. I want to say it's called Girls Night Out. I think it's the name. I don't know that they have a published manual yet. I know that they have a program and they've researched it, and there seems to be some good outcomes. It's just focused on females on the spectrum, not necessarily around dating, but around just kind of general social skills, which are applicable, of course, to romantic relationships as well. So that's the one program that I'm aware of that's really focused on adult females. And so I would definitely reach out to Dr. Jameson at University of Kansas, see where they're at. I know that they're interested in publishing a manual. I'm not sure where they're at with that at this point, but that would be a good resource.
Yeah, and I would say that the CAN clinic has been running some, social support groups as well, and we have one for females. We've been kind of splitting them a little bit because there is kind of a uniqueness to being, I think, well, being a man or being a woman on the spectrum. And so this idea that we're bringing people together who share more commonality, because I know Liz and I often feel overwhelmed by the maleness in our peers groups, the Peers for Careers group, and the women sometimes like to get together. And so we're trying to find ways to bridge connections as well, because we know that actually clinically, I know that many women are receiving first-time diagnoses in adulthood. And so that's a really profound experience as well.
And so in the final minute that we have remaining, Amanda, I was wondering if you could provide some guidance to families about where they can find more resources when they have an adult with ASD that they're taking care of.
Yeah, I mean, I think it's hard. I'll be honest with you. I mean, if you knock down the door of academic settings, and usually there's clinical programs that I feel like are pretty good near kind of academic settings. But there's also a fair amount now available, on the web. I think you just have to be careful about the site. I often steer families to the Autism Speaks website, just because they've done a pretty good job of focusing on issues around transition, and they have a transition toolkit for families that covers concepts such as guardianship and setting up finances and financial planning tools, and all of these things that come into play for individuals in adulthood, but we don't often think about. Regional centers should also provide support throughout the lifetime for individuals with ASD, but we find that can be a struggle, especially for individuals who are more, verbal and higher IQ. And so there's also the Department of Rehab. I think there are different, unfortunately, I was hearing John Constantino talk about the fragmentation. I mean, that's essentially what's happening. There's service silos everywhere, and you have to literally have a PhD in navigating this to really figure it out. But there are a lot of federal programs and state funded programs that will provide things like vocational training and job placement and job coaching. There's the Self-Determination Act of the regional center that is different from what I was talking about, which is kind of a philosophy, but self-determination is through the regional center as well, where families can decide what services their individuals get.
So I want to thank our panelists, Dr. Lageson and Dr. Goldsrud, and thank our audience for submitting some really great questions. And I think we need to move on to the next session now. So thanks everyone for a really interesting panel.
Yeah, thanks everybody. Thanks, Mike, for moderating that, and both Amanda and Liz for for spending the time, and especially Liz beyond the call of duty. Although we're all kind of slightly jealous as well. So the next and kind of last session is going to be moderated by our own Susan Buchheimer, who's the director of our IDDRC, and she has a very long CV with a lot of awards as well. I'm going to refer you to her website for that, but she's going to introduce John Elder Robison and have a conversation with him. He's a self-advocate, and we're really thrilled to have him here. And thanks to Susan for your moderation.
Thank you so much, Dan. Thanks for the introduction, and a special thanks to John Elder Robison for agreeing to come and be our self-advocate speaker today. John Elder Robison is an autistic adult who grew up undiagnosed and, in his terms, wild in a world of machines. At 16, he was lord and master of a small tractor and a CDC 3600 computer. By the age of 20, he conquered several more sophisticated devices while working for Britannia Row Pink Floyd's sound company, and Kiss, for whom he designed fire-breathing special effects guitars. In search of greater challenges, John went on to design power systems for our country's last underground nuclear tests, and he went on to establish a business restoring classic motor cars and developed a second career in performance photography. He continues to do both today, in addition to being the neurodiversity scholar at the College of William and Mary and advisor to the Neurodiversity Institute at Landmark College. In the spring of 2020, John completed 8 years of service to the NIH, where he served on the Interagency Autism Coordinating Committee. This is the group that produces the strategic plan for autism in the United States. John remains a neurodiversity advisor to the Lawrence Livermore National Lab and a consultant to SAP and other companies in the Autism at Work and Neurodiversity at Work initiatives worldwide. John has also served on the World Health Organization committees that have created the standard definitions of autism and exceptionality for the world. John is also a New York Times best-selling author of Look Me in the Eye, Be Different, Raising Cubby, and Switched On. He's appeared on a number of radio and television shows and written numerous articles on such diverse topics as rebuilding a Bentley 6.75-liter V8 engine, secrets of photographing circus performers, and how autistic Polynesians may have colonized the Southwest Pacific. He lives in Western Massachusetts with his wife, Mary Pat, a bulldog, and an imperial Chinese war pug. John has been a tireless advocate for neurodiversity, and we are honored to have him here today. Thank you so much for joining us today, John.
Well, thank you for having me here. So
That's great. And good. And it is, as in the other talks today, we're asking speakers to just talk a little bit about the videos. I hope that the audience has seen them. If you have not, please do. There are 2 of them. They're really fantastic videos that John has made. But John, I thought you might begin by telling us a bit about what neurodiversity means to you and why this is an important concept.
Well, when I first received an autism diagnosis, that was in the 1990s, and it was what they called an Asperger diagnosis then. I, on the one hand, was really relieved because for the first time in my life, I had a constructive explanation for why I had a lifetime of social failures and why I had struggled in certain areas. People called me retarded and mental and stupid and lazy and sociopathic and all kinds of names. And the realization that, no, this is, autism. It's not something like that. And I'm not just a bad or a lazy person. Well, that was really liberating. But then, it kind of sank in that, well, I've got this autism thing. There's no cure. It's never going to go away. And of course, I thought, well, now I've got an explanation for my failures, but I'm always going to be failed. It's how I am. It's what they're telling me. I realized, though, and this was a really empowering thing, and I realized that now that I knew how I was disabled relative to other people, I could conduct myself in a way that minimized the disability. So, for example, if I couldn't, read your body language, I could teach myself to be better mannered. And if you thought I was polite, then when I misread your, body language or whatever, you would excuse it because I was a nice guy. And that was, simple as it sounds, incredibly transformational for me. But I still was left with the feeling that I was a second-class human learning how to fit in a world of fully functional people, which I was not. Now, after I wrote my first book, as you know, I was invited to take part in a lot of different kinds of autism studies, to advise people on autism research and so on. One of the things I got involved with was a series of tests of cognitive abilities. And, other folks on the spectrum have done these kinds of things too. And in the course of doing those tests, I discovered that while I do have some abilities that are at child's level, like my ability to read your facial expressions, there are other abilities like recognizing patterns in seemingly random arrays of things and taking waves, such as in music, and putting them together in my head and figuring out what the result will look like and sound like. Those abilities are way off the charts in the other direction. So I had always thought, even though you read this list of accomplishments that I've had, I always thought, well, sure, I was a successful engineer, but that's only because a real engineer wouldn't be wasting his time doing rock and roll music. He'd be designing something important. And of course, you might think, well, I worked on, designing stuff for Livermore Labs. That was important national defense work back in the 1980s. But, I quit that because I thought, well, I'm not a real engineer. I can't be doing this. They'll put me in jail if they find out I'm not a real engineer. But in fact, what I learned in those cognitive tests is that most engineers do not have the abilities that I did to do those things, and that those are truly exceptionalities. And that was the point where I realized that people like me are not just packages of disabilities that have to learn how to get by. We often have exceptionality. And a few years later, when I was invited to serve on the World Health Organization steering committees for autism, and we had the revision of the ICD and then the creation of the Autism ICF core set. In that creation of that core set, I pushed for language to describe autism as disability and exceptionality. And everywhere else in the WHO's scoring of human function, they only measure your deterioration from the standard level. But in the case of scoring a person with autism, we can score certain cognitive areas as degrees of superior from average and degrees of impaired. And so the idea of neurodiversity is that a certain amount of neurological diversity is a part of humanity. And the reason it's a part of humanity is that there is a necessary trade-off. The parts of my brain that can't read emotional cues can put together complex waves and do things that are useful to society. And so there is a constructive purpose for these differences, even if they come at the cost of painful disability. And I think the idea of neurodiversity is that there are a significant number of people who have different brains, who were born this way, who aren't defective, who aren't broken, who are disabled, but also exceptional. And I recognize that there's a point where you're going to say, well, difference and exceptionality shades into serious disability, and that's true. But it's all within the range of human diversity that we're born with. So that's the idea behind neurodiversity. It's to put the conversation in a different context. So we're not talking about just brokenness. We're talking about the balance of disability and exceptionality.
Thank you. That's a really great description of neurodiversity, and I think very much in keeping with what we really know to be true about the evolution of individual differences, that any behavior that we have must be adaptive in some way, and maybe it's just on us to figure out how that is adaptive. We do have a question from the audience that is related to what you've just been talking about, and I would like to read it to you. Disability implies having difficulty in doing what one wants, needs, or perhaps would love to do. We treat neurodiverse individuals who have difficulty stopping themselves from doing what they ought not to do, with the possible risk of offering neurodiversity as a defense. But how do you conceptualize and accommodate to the surface tension between neurodiversity and disorder?
Well, that's not actually how I heard those words. I think what you read me was that people attempt to offer neurodiversity as a defense, and I might presume to think that that's a defense against crime. And I actually have served our courts and our other organizations in government as an expert on autism in the criminal courts. Being possessed of a different brain does not excuse you from breaking society's rules. Being possessed of a different brain doesn't excuse you from doing something that we judge to be morally wrong. I would say a different brain, autism, let's say, neurodiversity is absolutely not a defense against any crime, period, because neurodiversity is not a recognized medical condition, but autism is, okay? So you could say, is autism a defense? Autism is absolutely not a defense against committing a rape or some other kind of sexual assault or committing an assault, a violence upon another person. Absolutely not. Just because you're autistic, it doesn't change the fact of what you did. Where autism comes in is in compassion and function in sentencing. So, for example, if you believe that a child should not be sentenced to death for a heinous crime like murdering several people, many people believe that children should not be put to death. It stands to reason then that you would believe that a person with an intellectual disability who was not capable of fully formed adult thought and reason and understanding about perhaps morality and what he was doing, that person should not be put to death, even though he were guilty of such a horrific crime too. And if you accept that premise and you understand as a medical professional that autism represents a developmental delay, then a person with autism who is especially a young adult, you might think it's a reasonable argument that that person would not be executed for committing a heinous crime because he had an unformed intellect because of his disability. That is not an argument that the person is not guilty. That's an argument that such a person is deserving because of brain difference of mercy or compassion. The other example where we see that in the courts is for example, an autistic person who connects with people who are much younger. And when that person is 12 years old and all his friends are 5 years old, teachers think it's funny. But when that person becomes 23 and he has all the hormonal urges of a 23-year-old guy, and now the love of his life, or so he imagines, is a 14-year-old girl, now we have a situation where someone calls the police. And so I think it's very reasonable to ask, is that person who has, in many cases, a significant cognitive disability, is that person a dangerous sexual predator in the same way that the 35-year-old man preying on an innocent young person in a television story? Are those the same kinds of pictures that are being painted? I think not. And so I think, again, you can argue not only for compassion in sentencing, because both people are definitely guilty, but you can also argue that the autistic person in that case is likely to be able to be taught what would be acceptable behavior and therefore not be a repeat offender, where other kinds of sexual offenders do not have that positive outcome. So I think that we should be very clear that autism is in no case a defense against committing a crime, but autism may be a reason for asking for compassion or more constructive sentencing.
Thank you, John. I think that part of the question really is more about, do we focus more on changing a person's behavior that looks, that maybe is different, versus teaching them new behaviors that can help the individual. Sort of this balance between, I have autistic-like behavior. Should we try to find ways of celebrating them as different, or shall we try to find ways of changing those behaviors to make them more, conforming. And I think that one of our questions.
That's a very different question. The idea of changing or normalizing our behaviors or accepting our behaviors, that is at the root of the controversy that is bubbling around ABA, applied behavior analysis. And I think that at the heart of it, you have to ask yourself, if you're looking at an autistic person who is exhibiting an unusual behavior, is the behavior something that will get them accused of committing a crime? Like, an example of that would be an autistic person who says, well, I don't have a girlfriend, but I'm going to put a camera in the girls' shower in my dorm and I'll watch girls there. Okay, so and you smile at that, but those are real court cases. And those are terribly frightening things for parents when all of a sudden their autistic kid who just had this thing that you would think, oh, it's just a dumb idea. Now he's facing 10 years in a federal prison over that because the camera image was transmitted over state lines and it becomes transmission of child pornography over state lines. So you have to ask, is it a crime? If it's a crime, absolutely, you have to suppress that behavior. You have to teach the person that it's a wrong thing to do that will destroy his life potential. Then going beyond that, if we look at rocking back and forth, more, less severe behaviors, you can ask yourself, is this a behavior that will get my child or this person I'm, looking at, if it will cause them to be bullied or ridiculed or come to harm? And if the answer is no, it won't cause them to come to harm, then I think that you should recognize that we do these things for a purpose. So even, the first example I gave you, he's spying on girls to learn about girls. Maybe it's the wrong way, it's illegal, we can see that, but he had a purpose in his mind. And so the autistic person is rocking back and forth also has a purpose, even if it's inscrutable to you, has a purpose. And if it's a harmless thing and it's comforting to that person, absolutely, we should let them do it. And I think if you are the autistic person like me, and you're thinking, should I change myself or should I ask the world to accept me as I am? I think that we all have to recognize that we only get one chance to meet people for the first time. So if I conduct myself in a way that when I meet you for the first time, you look at me and you say, boy, that guy's weird. That guy's unfriendly. That guy's, aggressive. He's this or that. Our encounter won't go well. And if I want you to like me, I need to teach myself to behave in a way that will cause you to think, he's a nice guy. I don't mind having him back. I'd like him in my program. I'd like him working in my company. I'd like to be his friend. So we have to all learn to act in ways that people welcome us. And that's not because we're autistic, it's because we are humans who want to have successful social interactions.
Thank you. That's a really great point of view. We have a semi-related question from the audience. They ask, is there a resource you would recommend about explaining ASD diagnosis to a person who was recently diagnosed that you believe is also strengths-based? How would you explain to such a person about their ASD diagnosis that you think will emphasize the kind of things you're talking about, and are the resources that you're aware of to help with that?
Well, I wrote 2 books to address that a number of years ago. Look Me in the Eye and Be Different speak exactly to that question. Look Me in the Eye is a book that has been read by millions of people. And I would say, if you read that story and you say, boy, I didn't do exactly the same things Robeson did, but the kind of trajectory of his life, that's just like me. That's just like my son. That's just like my, my whatever. It's just like, if you see yourself or your family or loved ones in that story, I think it is a story of triumph. And not only is it a story of triumph, but it's a story of doing things any of you could do. But that's only a memoir about my life. People, after I published that book, said to me, well, you didn't talk about all these other problems that come with autism. How about my son who can't wear scratchy sweaters, and you're wearing a sweater? How can you do that? How about, this? How about that? And so to answer those questions, I took all of the traits of autism and also for the most part of ADHD, and I wrote stories describing how those traits affected me, and either how they were disabling to me and I just tried to minimize the disability, or how they were both disabling and a gift to me. And you might wonder, well, how could it be a gift and a disability? Here's an example. Let's say that you have, a child, and your child is really, really interested in dinosaurs, and he does not care at all about social studies. He does not care about gym, and he does not care about math class, and he does not care about English and spelling. He cares about dinosaurs. And that kid is going to be in trouble in school. The teachers will say he's failing at all these other classes, even though he knows more about dinosaurs than any other kid in the school. And maybe he's going to go on to have some other different kind of adult interest. Maybe he will be like my autistic first wife, where he is still interested in as an adult, not just in dinosaurs, but in bones. And he goes to grad school, and he gets a doctorate in anthropology. And he goes to work for the state medical examiner, and he's the one person in the state that you can turn to look in a moment at a bone that comes up in a farmer's field and tell you if that's a recent murder victim or it's a 5,000-year-old Native American, or even more so, if that bone is even human or if it's from some kind of animal. And the person who can do that, who has that lifelong fixation on knowing 100,000 different bones, that person's a star as an adult, even though they were disabled as a child by the very same trait. And right. and she was a true living example of that.
That's fantastic. We've got a couple more questions, and not a lot of time. Let me ask you this one. What do you think what could change in the school system to make growing up easier for kids who were different like yourself?
I think that's a real hard problem to solve in a nation where we have Common Core and standardized testing. Because I think that the root of the problem is that in the real world, Common Core and test scores do not matter in the performance of a job. So if I failed an English test because I can't tell subjects from predicates and participles and adverbs and adjectives, so what? If I can write a book that people will read, if I can craft a story that is well told and easily understood, that's the job, not knowing adverbs and adjectives. We have a fundamental misalignment between testing for things that don't matter and failing to teach things that do matter. And so as long as we are doing that, when people with different brains teach themselves how to construct language, how to solve math problems, how to design electronic circuits, when we don't respect that, and we instead say, if you don't do it by the book, it won't count, it ain't gonna work, folks. And that's why you see people who are different finding success in programs like Montessori, why they can find success in home education. I would say for those of you looking at sending a kid to college and thinking, could my child go to UCLA despite having autism, ADHD, or whatever? One thing you might think about is sending a child from high school to Landmark College in Vermont, which is the only college in America at this time specifically aimed at neurodivergent people with a neurodivergent staff, meaning you have autistic people teaching autistic people how to be ourselves. And Landmark is a place where they can teach the skills you'll need to function in a neurotypical world in a college environment like UCLA. So that would be a constructive suggestion. And as for high school, I frankly don't have a suggestion for public schools short of major reform. And the other thing I would say, and we're doing this in schools, is as we move back to the model of vocational education or learning by doing, when we start to teach trades in high school and we evaluate a student on the ability to craft a nice project in wood shop or fix a machine in metal shop or make a thing in metal shop, when we test for results, autistic people are not disadvantaged in the same way.
Good point. So we have very little time, but there's one more question from the audience I'd like to ask. As a parent and neurodiverse person, how do you think the family should be considered in the support services to promote self-determination and enhance the strengths of neurodiverse people?
Well, I'm not completely sure what you're asking me. I am a neurodivergent person and I am a neurodivergent parent also. Now, I don't know about you being the person who asked the question, but after my more than decade serving our public health agencies, I do know that science tells us that this neurodiversity apple doesn't fall too far from the tree. So probably 75% of neurodivergent people have neurodivergent parents, siblings, other family members. And so the first step is recognize that you are all in this together. Maybe you're looking at your kid because kid can't pass English, can't pass math, can't make friends. And maybe, you could be looking at yourself and thinking, boy, I don't know where I would have been if I hadn't met him or her being, your kid's mother or father, because I had no ability to make friends, or maybe you think, they're telling me about my kid's fixation on these books, and that's why I'm a successful lawyer, or they're telling me about my kid's this or that. That's why I'm a successful cabinet maker. You have to look at those traits and what they might mean in different contexts. And when you realize that those traits are in you, maybe they're not in you, maybe you're in your husband, your wife, your mother, your father, and those are all successful people. And you see that these are not just traits of failure, they are traits of success too. It's going to change your outlook towards dealing with the school. And this is not a matter of denying disability. Disability is real. If you can't do what they want, you're failing, no doubt about it. But it doesn't mean you can't achieve success as an adult. And that's what this is about.
Thank you, John. That is really a tremendous point, and I think really culminates what we all believe here at UCLA. And I think it's a really nice ending point for our meeting today, for our conference. So I want to thank you and also encourage the audience to read John's books, especially Raising Cubbies, very inspirational. And thank you so much, John, for being with us today and for giving your personal story and your insights. And I'll turn it over to you.
For having me on.
Thank you so much. Dan, I'm going to turn it over to you.
No, thank you very much, John. That was, it's really a spectacular explication of this tension, right, between having extraordinary abilities and ability and disabilities. And I think I want to thank Susan for moderating that, but it really does, it's a great way to end, because it just reminds us that we all have strengths and weaknesses. It's kind of reminded me to a time when I remember there were some papers showing on IQ tests that even people, something like a fifth or so of people on a major IQ test will perform abysmally on at least one subtest, so that even people with extraordinary, everybody has strengths and weaknesses. Nobody is actually average. And I think we have to recognize that here. But the notion that we can have disabilities that we have to deal with, I think is important to accept in a way that it doesn't negate your abilities and ability to contribute to society. So John, again, thank you so much. This is, essentially the end of the day. I want to thank all of you for attending, for coming, because by coming, you really made this a worthwhile event and for participating and asking questions. I also want to thank all of the speakers and moderators for their time and effort, especially our two guest lecturers from outside and our two plenary lectures as well. I'm told to remind you to fill out the evaluations. We take all of this very seriously, and we try to improve our program every year. Let us know if you like this, this format, if there were things that were useful or things we could improve. Again, that would be extremely helpful. I hope dearly that next year we'll be able to do this and see each other in person. But perhaps this gives us a way to do things and reach people in a way that telehealth does outside of our driving distance. But as I say, often within LA, the driving distance is usually only 2 or 3 miles. Anywhere beyond that, it could take hours to move across LA. So again, looking forward to seeing everybody next year or before, hopefully. Please look at our website, stay in touch with us, engage us. We really appreciate that. And thanks to all the speakers again, and everybody be healthy, be well, and have a great weekend.